commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the archipelago, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after, evidence that the quality of our education meets international standards. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world.
Ladies and gentlemen, before we begin today's seminar, we would like to inform you that there is a barcode displayed on the screen. All participants are kindly requested to download Satu Sehat application through the Play Store or App Store. After downloading, please submit the proof of download through the link that provided in the barcode. Thank you for your kind attention. Okay, ladies and gentlemen, now I will read the participant rules. Registered participants will be sent a Zoom ID and password after registering via the URL that will be sent to the International Seminar WhatsApp group. Participants are prohibited from sharing their Zoom ID and password with others. Access to Zoom will be available 30 minutes before the event begins. Participants must join 15 minutes before the event begins. Participants must fill in the attendance list before and after the seminar starts. The attendance link will only be active for 30 minutes. To fill in the attendance list after the event is over, it is requested for each participant to prepare a screenshot of proof of attendance. Participants are required to use real names, not device names or institution names. For internal participants, please use format internal_name. For external participants, please use format external_name. For participants from Health Information Management, please use format HIM_name. And for general participants, please use format general_name. All material present will be shared to the International Seminar WhatsApp group. Participants must attend all seminar sessions from beginning to the end. Participants must take the pre-test and post-test held by committee. Participants must turn off the microphone during the course of the seminar, unless requested to be activated by the committee. Participants who get access to Zoom must dress and behave courteously during the seminar. All participants who are attending the seminar via Zoom can ask questions by type ask. Continue by writing your name, institution name, and question briefly. The moderator will be convey the speaker several questions that will be selected by the committee due to the limited discussion time. Participants who do not fill out the registration Google form before the event starts or do not fill the attendance list after the event is over will not receive a certificate. Hopefully, our requirements can be followed by all participants.
Synopsis title Nyaah Karaga or Love Your Body. Cancer is one of the deadliest diseases in the modern era. Although medical advances have increased life expectancy for many cancer patients, the disease remains a serious threat to many people. Lifestyle, environmental, and genetic factors can increase the risk of cancer. This creative dance performance is a call to adopt a healthy lifestyle and raise awareness about this disease, especially among the younger generation. We hope this creative dance performance can educate the public about the importance of caring for one another, supporting each other, and boosting the confidence of those affected.
Hello everyone! Let us introduce ourselves. We are from Wirasagita Raga, Poltekkes Kemenkes Tasikmalaya. We will be presenting a dance entitled Nyaah Karaga or Love Your Body. Happy watching. Thank you. Bye.
Hello everyone! Hello Miss! Today's topic is about cancer. Cancer has been around since ancient Egypt 3000 BC. Cancer is very dangerous disease. So, we have to protect ourselves from getting cancer. Thank you, Miss! Sadness, despair, loss of direction, and trauma are the first thing people feel. However, that's not the solution to all problems. Support from those around them is crucial for the health of those infected. Love, protect, and care for yourself.
Assalamualaikum warahmatullahi wabarakatuh. With healthy regards, good morning, good afternoon, and good evening, ladies and gentlemen. On behalf of the organizing committee, I would like to express our gratitude for your presence at this international seminar. Welcome to the 5th International Seminar Medical Record and Health Information with the term From Data to Decisions, Leveraging Big Data for Population Health and Preventive Care. The Honorable Director of Health Polytechnic of the Ministry of Health Tasikmalaya, Dr. Dini Mariani, Bachelor of Nursing, Nurse, Magister of Nursing, who will be represented by Vice Director 1 of Health Polytechnic of the Ministry of Health Tasikmalaya, Dr. Afsep Kuswandi, Bachelor of Nursing, Nurse, Master of Nursing, Specialist in Medical Surgical Nursing. The Honorable Head of the Medical Record and Health Information Program of Health Polytechnic of the Ministry of Health Tasikmalaya, Andi Suhenda, Bachelor of Public Health, Magister of Public Health. Our distinguished invited speakers, Professor Susan H. Penton, Doctor of Philosophy, Registered Health Information Administrator, Advanced Certified Health Information Professional, and Fellow the American Medical Informatics Association, who will be represented by Dr. Uday Pratap Singh from the University of Texas Health Science Center at Houston, United States. Professor Emily Chia Yuzu, Doctor of Philosophy, National Yang Ming Chiao Tung University, Institute of Biomedical Informatics, Taiwan. Debbie Shahrul Ramadlon, Master of Science in Nursing, Registered Nurse, Doctor of Philosophy, Faculty of Nursing, Chulalongkorn University, Bangkok, Thailand. Dayana Barsasela, Magister of Public Health, Doctor of Philosophy, Health Polytechnic of the Ministry of Health Tasikmalaya. The Honorable all Lecturer and Staff of Health Polytechnic of the Ministry of Health Tasikmalaya, the Honorable Chairman of the Medical Record and Health Information Student Association of Health Polytechnic of the Ministry of Health Tasikmalaya, our respected moderators, Safian Jani Audanisa, and last but not least, all distinguished participants who are joining us virtually from Indonesia and abroad. Before we begin, allow me to introduce myself. My name is Salma Azkia Agustinisa, and I'm honored to serve as your Master of Ceremony that will guide today's international seminar. Ladies and gentlemen, let me to present a brief outline of our program today. First, opening. Second, listening to the Indonesian National Anthem, Indonesia Raya, followed by the Health Polytechnic of the Ministry of Health March. Third, opening speech from Director of Health Polytechnic of the Ministry of Health Tasikmalaya. Fourth, speech from Chairman of the Medical Record and Health Information Student Association of Health Polytechnic of the Ministry of Health Tasikmalaya. Fifth, seminar session that will be delivered by our distinguished speakers. And the last, closing and documentation session. Ladies and gentlemen, the first agenda is opening. Let us open this international seminar by reciting Basmalah together. Bismillahirrahmanirrahim. The second agenda, let us listen to the Indonesian National Anthem, Indonesia Raya, followed by the Health Polytechnic of the Ministry of Health March.
Indonesia mengabdi nusa dan bangsa, berbudi luhur, berakhlak berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes di Indonesia, bekerja profesional mendunia. Semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti di Dharma sebagai pedoman kami. Membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes di Indonesia, siap mengabdi nusa dan bangsa, berbudi luhur, berakhlak berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes di Indonesia, bekerja profesional mendunia. Semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti di Dharma sebagai pedoman kami. Membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes hebat, Indonesia sehat.
Ladies and gentlemen, we kindly remind our participants to fill out the attendance form that has been shared by the committee in the Zoom chat. Once again, we kindly remind our participants to fill out the attendance form that has been shared by the committee in the Zoom chat. Okay, the third agenda, we will listen the opening speech from Director of Health Polytechnic of the Ministry of Health Tasikmalaya. We are honored to invite the Vice Director 1 of Health Polytechnic of the Ministry of Health Tasikmalaya, Dr. Afsep Kuswandi, Bachelor of Nursing, Nurse, Master of Nursing, Specialist in Medical Surgical Nursing. To Dr. Afsep Kuswandi, the time is yours.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, distinguished speaker, and the honorable participants. It is great honor and privilege for me on behalf of the leadership of the Poltekkes Kemenkes Tasikmalaya to warmly welcome all of you to the 5th International Seminar and Medical Record and Health Information 2025. Ladies and gentlemen, this year theme from data to decisions, leveraging big data for population health and preventive care truly reflects the future direction of healthcare innovation. In an era where data drives every decision, our ability to collect, interpret, and utilize health data accurately determines the quality of our healthcare system. Today's seminar brings together experts, researchers, practitioners, and students from various countries: Indonesia, the United States, Thailand, and Taiwan, to share ideas, knowledge, and experience. This collaboration demonstrates our shared commitment to improving our global health outcome through the intelligent use of health information. I sincerely appreciate to all keynote and invited speaker, Professor Susan Fenton, PhD from the University of Texas Health, USA. For Emily Chai Yusu, PhD from National Yang Mingchou Tung University, Taiwan. Debbie Shahrul Ramadan, PhD from Chulalongkorn University, Thailand. And our very own Daina Barsasela, PhD from Poltekkes Kemenkes Tasikmalaya, Indonesia. Your presence here signifies of shared vision for strengthening evidence-based healthcare, empowering data-driven decision making, and enhancing preventive strategies for community well-being. I would like to extend our appreciation to the organizing committee, especially the head of Department of Medical Record Health Information, Mr. Andi Suhenda, and team for their hard work and decision in making this international event possible. Finally, I encourage all participants to take this opportunity to learn, collaborate, and engage activity throughout the seminar. May this event inspire us to translate health data into meaningful action for better and healthier world. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you to Dr. Asep Kuswandi for your warm opening speech and inspiring words. The fourth agenda, we will listen the speech from Chairman of the Medical Record and Health Information Student Association of Health Polytechnic of the Ministry of Health Tasikmalaya, to Randi Aulia Rahman. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Greeting to everyone, the Honorable Director of Health Polytechnic of the Ministry of Health Tasikmalaya, Dr. Dini Mariani, Bachelor of Nursing, Nurse Magister of Nursing. The Honorable Dr. Asep Kuswandi, Bachelor of Nursing, Magister of Nursing. The Honorable Head of Medical Record and Health Information Program of Health Polytechnic of the Ministry of Health Tasikmalaya, Mr. Andi Suhenda, Bachelor of Public Health, Magister of Public Health. Our distinguished invite speaker, Professor Susan H. Penton, Doctor of Philosophy, Registered Health Information Administrator, Advanced Certified Health Information Professional, and Fellow of the American Medical Informatics Association, who will be represented by Dr. Uday Pratap Singh from the University of Texas Health Science Center at Houston, United States. Professor Emily Chiayusu, Doctor of Philosophy, National Chiang Tung University, Institute of Biomedical Informatics, Taiwan. Mr. Debbie Shahrul Ramadan, Master of Science in Nursing, Registered Nurse Doctor of Philosophy, Faculty of Nursing, Chulalongkorn University, Bangkok, Thailand. Mrs. Diana Barsasela, Magister of Public Health, Doctor of Philosophy, Health Polytechnic of the Ministry of Health Tasikmalaya. Lecturer and staff of Health Polytechnic of the Ministry of Health Tasikmalaya, and all participants and the international seminar. First of all, let us express our gratitude to Allah Subhanahu wa Ta'ala for His grace. We are able to gather and participate in the 5th International Seminar on Medical Record and Health Information. The theme we are raising at this international seminar, namely From Data to Decision, Leveraging Big Data for Population and Healthcare, is very relevant to development in this digital era. Amidst rapid advance in information technology, the use of big data play an important role in effort to improve the quality of health service and public health. Through proper data processing, the information generated can be used as a basis for more accurate and evidence-based decision making, thereby supporting the realization of health system that is effective, efficient, and oriented toward the need of the community. On this occasion, I would like to express my deepest appreciation to all the committee member and faculty who have worked diligently to make this international seminar a success. We also hope that participants can follow this event from beginning to end, so that they can gain the maximum benefit from each session presented. We hope this international seminar will serve as beneficial platform for exchanging knowledge and experience in the field of the medical record and health information, as well as opening opportunity for future collaboration. To conclude my welcome speech, thank you for attention and thank you for participation. Wassalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, before we move to the next agenda, let's take a moment for a documentation session. We kindly ask our participants to turn on your cameras and give your best smile for our photo session. I will count from slide 1. 3, 2, 1. Okay, slide 2. 3, 2, 1. Okay, slide 3. 3, 2, 1. Okay, slide 4. 3, 2, 1. Okay, slide 5. 3, 2, 1. Okay, ladies and gentlemen, slide 6. 3, 2, 1. Slide 7. 3, 2, 1. Slide 8. 3, 2, 1. Slide 9. 3, 2, 1. Okay, slide 10. 3, 2, 1. Slide 11. 3, 2, 1. Slide 12. 3, 2, 1. Okay, ladies and gentlemen, before we entering the main agenda of today's international seminar, please remain in this main room Zoom as we begin the presentation, which will be delivered by our distinguished speakers from Indonesia, United States, Thailand, and Taiwan. Allow me to introduce our moderator for this presentation session. Sofianjani Auranisa. She is a third-year student of Department Medical Record and Health Information of Health Polytechnic of the Ministry of Health Tasikmalaya. We are delighted to have her as the moderator for this session. Ladies and gentlemen, please welcome Sofianjani Auranisa.
Thank you very much to our Master of Ceremony for the kind introduction. Good morning, good afternoon, and good evening to everyone joining us across the globe. It's a pleasure to welcome you to today's session of our international seminar, From Data to Decision, Leveraging Big Data for Population Health and Preventive Care. I'm Sofianjani, your moderator for today's session. We are excited to learn, share, and explore valuable insights together with our esteemed speaker. Let's make this session intriguing, inspiring, and meaningful for all of us. Everyone, before we get to the main event, I would like to take a look of the profile video of Tasikmalaya Polytechnic of Health Majors.
Selamat datang di Poltekkes Kemenkes Tasikmalaya Prodi D3 Rekamedis dan Informasi Kesehatan. Yuk kita cari tahu lebih dalam tentang prodi ini. Di Prodi EMK terdapat ruangan laboratorium, statistik, dan pelaporan. Let's go! Prodi D3 RMIK memiliki laboratorium coding klinis dan reimbursement. Yuk kita lihat. Nah, yang tadi adalah laboratorium coding klinis dan reimbursement elektroniknya. Sekarang yuk kita ke ruangan manualnya. Prodi kita memiliki laboratorium manual yang sering digunakan untuk praktik mahasiswa atau mahasiswi RMIK. Selain itu, Prodi D3 RMIK punya seragam yang gak kalah keren. Yuk kita lihat.
Everyone, we kindly remind you, for those who haven't downloaded the Satu Sehat application, don't forget to install and log in on Satu Sehat application. Allow me to remind you again, please fill the attendance form that was submitted in chat box. For everyone who have issues with the LMS, please wait for our verification.
Tadi ada suaranya nggak sih Mbak Di? Belum ya? Masuknya sih bisa, cuma nggak ngerti ini nggak ada suaranya dari sananya atau dari headset.
And we kindly remind participants to do the pre-test. You can access the pre-test through the chat box, which will be shared by the committee in the Zoom chat. The pre-test will begin in 20 minutes, so take your time. Thank you for everyone who already do the pre-test. Now, we are moved to our main agenda. Dear participant, we would like to inform you that Professor Susan H. Fenton is unable to join us today due to schedule constraint. However, we are very pleased to welcome her doctoral student, Dr. Uday Pratap Singh, who worked closely with her at the University of Texas Health Science Center at Houston, United States, and will be representing her in today's session. We truly appreciate Dr. Uday for being here and continuing the discussion with us. To begin, allow me to introduce our speaker. Dr. Uday Pratap Singh is a PhD student in Biomedical Informatics at University of Texas Health Science Center, Houston, United States. He has an extensive background in dentistry, oral medicine, and radiology, and has since focused his expertise on data science and biomedical informatics. Dr. Uday's professional experience include clinical data science and electronic health record optimization. His current research integrated process mining, machine learning, and large language model to support clinical decision making. One of his notable projects, FamScan, an AI-based pipeline for family history extraction, has received recognition at major forums such as AMAA. Today, his presentation will explain how big data can be processed into information and insight that support decision-making in planning, policy, and improving health service at the population level. We are truly honored to have him with us today. Please welcome our speaker, Dr. Uday Pratap Singh.
Hi, very good morning. Thank you so much for giving us this opportunity. Just confirming, is my audio coming through okay?
Yeah, I can hear you. Doctor.
Excellent. Okay. So, I am currently sharing my screen. Can you please confirm if my screen is visible?
Yeah, it's already visible.
Excellent. Thank you. So, once again, thank you so much for considering us for this opportunity. I'm grateful to Dr. Susan Fenton for considering me for this opportunity. And it's a very interesting and important topic, from data to decisions, leveraging big data for population health and care. So, may I begin?
Okay, just a quick reminder about our session
Yes.
format. You have 45 minutes for your presentation, followed by a 15-minute discussion. And don't worry about the time. I will help manage it and give you a gentle reminder as we approach each segment. Are you all set, Dr. Uday?
Oh, yes, absolutely.
Alright,
I'm
so
really
we can
excited.
start now. Okay.
Awesome, awesome. Thank you so much. So, thank you. The objectives and key takeaways for this session is to describe what big data is in healthcare and where does it come from. Explain how big data supports population health decision making, from identifying problems to selecting solutions, and to interpret real world examples where big data has been used to guide policy, planning, and care delivery. So let's first start with data. So, data, what is data? Data are details that have been observed, recorded, or measured. It could be a number, a photo, a lab result, or a temperature. On their own, it generally does not mean much. But when it is contextualized, organized, and interpreted, it allows us to learn something. So the pipeline is data to information to knowledge. And then with this knowledge, hopefully, we can make some decisions. So let's first understand very quickly what do we mean by data. If I give you 98.6, what does it mean? 98.6. It could mean anything. It could mean a body temperature that says that yes, there is no fever. It could mean a very nice book, 98.6, that talked about cultural disillusionment. It could be of FM radio frequency, or it could also be a nice album of music. So the number itself doesn't have much meaning, but after giving it some context, we convert the data into some sort of information, and then we process it to gain some sort of knowledge. So, what are the sources of data in healthcare? So, of course, there are a lot of diverse sources. You have demographics, you have community generated data, you have electronic health records, you have wearable devices, you have environmental data, epidemiological data, genomic data, and market research data. So these data sets can be linked together and they can be collected over time. And these data sets, these different sources of data, reflect real world behavior. And it includes digital signals that we can use uh, to understand what's happening in reality. So now, if this is data and these are the sources of data, what is big data? So big data is generally not a single data set. It is created when multiple different data sources are combined at a decently large scale. And when these large, diverse data sets are linked and made available for others to use and derive meaning, they become big data. So big data is not a very old term, neither is it a very new term. There are a lot of things that happened that allowed us to have big data. So what are the facilitators for big data? Of course, a conducive environment, supportive policies and leadership, and of course, a commitment to creating this kind of a data set. This is, of course, also supported by funding and investment, and of course, public interest and stakeholder engagement. So, very initially, we had just started with data infrastructure and storage long back, and then we started with standardization and interoperability that helped us make this data bigger. And once we integrated it across institutions, then we were able to uh, further enhance this data. And then computational power, data governance, ethics, and then of course now we have a skilled workforce. And this is a wonderful opportunity where we want to learn this skill of using big data. So if big data exists, but there is not a skilled workforce, then it's again of no use. So how is big data generated? So you remember these multiple sources of data, we add a layer of privacy protection. So we have these different sources of data, and to this data, we link all of this data, and then we add a layer of data confidentiality, access level permissions, data use agreements, de-identification, privacy protection, ethical and responsible use, and then interoperability and standardization. So we add a layer of protection so that when we use this big data for research, we are not making any mistakes in privacy protection. We are making sure that everything is standardized and we are doing ethical research. That's a layer of protection. And once this happens, then we can filter out relevant information from these different sources. And that's how big data comes into place. So this is, of course, turned into a shared data set which can be used. This is protected through access controls and governance, and it supports planning and policy and real world decision making. But it's important to understand that not every big data has all of these sources. There can be various combinations. For example, there can be a data set which has data from electronic health records, data from wearable devices and market research and epidemiology. It doesn't have demographics, doesn't have other sources. And there can be another data type which has EHRs, demographics, environmental data, and genomic data. So there are a lot of these big data sets available which we can leverage to make decisions. And what are the features of this big data? So the most prominent three features are volume, variety, and velocity. So what do they mean? Volume means massive amounts of data. Variety means it has clinical details as well. It has radiographic details, demographic details, genomic details, environmental and social media details, variable data sets. And velocity means it is being generated continuously. You have more and more data available for you to use and analyze. These are the big features of big data. But now the question is why? Why do we need big data? Why can't we work with small data? What is the advantage of big data? So big data helps us see the whole picture, not just isolated pieces. It helps us detect problems early before they become a crisis, helps us understand where something will have the greatest impact, evaluate what is working, what is not. And of course, it helps us make stronger artificial intelligence and predictive models. So imagine you have an artificial intelligence model which is based on one person. Will you trust it? You will not trust it because it is based on only one person. Now, if it is based on 100 people from one country of the world, will you trust it? Will you use it? Probably not. What if it is based on all the patients of a single country? Will you use it in a different country? Maybe within the same country it makes sense. But for other country, you will think this patient population is not representative of people in my country. But if you have data which is across different countries, which has a variety of different data types, the artificial intelligence which is used, which is developed using this big data, it will be a generic intelligence and you can use it for various applications. So the next question comes, who collects? Who is responsible for this big data? Who collects this big data and who maintains this big data? So hospitals and health systems, government and public health agencies, research institutions, biobanks, insurance and payer organizations, wearable device companies, and social media platforms. These are various stakeholders that have a responsibility for maintaining this data set, and they derive meaning in the community by maintaining these data sets. And if these are the companies who collect and maintain data, who can use it? Can anybody use it? Who uses this big data? So, whenever you want to use a big data for some sort of analysis, you need to have a consent and data ownership. You need to understand that this some many a times this data can be in silos across institutions. Access depends on ownership, privacy regulations, and data sharing agreements. So access is generally controlled, regulated, and purpose specific. So there are some big data sets that you have to apply for, and the application itself is lengthy and it takes time. You have to explain what you will do with this big data set, and you have to submit your analysis plan because these are big data sets and they should be used for deriving good meaning. And of course, many a times it's very important to understand that not every big data can be used for everything. So anyway, we'll discuss that in more detail. So now the next question is, okay, I understand what is data. Data is just symbols, data is just details. The context around this data helps me make meaning of this data. Then I talked about what is big data. Big data is when you accumulate data from various sources and you bring them together, link them together. Then I have variety, I have velocity, I have volume. Then I can use this data for various purposes. But how? What should I do? So let's say that we have big data. Let's say we applied for an application. Now we have access to a big data. What should we do now? So everything is based on the assumption that we can use this big data to better plan, inform, and revise population health and care. That is the biggest assumption. That is the biggest hope, that we can use this data to make a better decision for our population. It is an opportunity to generate actionable knowledge. And this knowledge will hopefully inform towards making the right decisions. So now it's a very important concept that we come to: decisions. What are decisions? So, a decision is a choice made between alternative courses of action. So, you have various options, and then you need to make a choice which choice would be the most suitable. And it generally involves three steps. Any decision involves three steps: recognizing a situation or need, considering available options, and then selecting and committing to one action. Now, all of you as individuals make decisions. All of you make decisions, but those decisions don't impact others. As elders, as parents, people make decisions for others, for people in their family. As institutional leaders, they also make decisions, and those decisions impact people within that organization. But decisions for population health and care, these are very difficult decisions, because your decision impacts the whole population. Unfortunately, even not making a decision impacts the community at large. So even if we decide, I don't know what is the best option right now, so let me not make any decision, this also impacts the community. So even not making a decision is a decision when we come to talking about population health and care. So, what am I talking about? I'm talking about what is a decision. If I know what a decision is, then I can use the big data to understand how I can make this decision better. Decision has three steps: understanding the situation or the problem, understanding what options are available with me, and then selecting and committing to one action, and then evaluating how this action is performing. Now, the next question is, for a population health and care purpose, who makes these decisions? So you have government and ministries of health. For example, there is vaccination policy, sugar tax, national screening guidelines. You have public health agencies that talk about outbreak response, prevention campaigns, sanitation initiatives. You have hospitals and care delivery systems that talk about how do we plan things for a certain area, how do we organize the workforce, what is the triaging capacity. There are decisions that impact population health and care by insurance and payers, by community organizations and NGOs, clinicians and care teams. For example, they make guidelines for patient care and chronic disease management. So these are some of the organizations that make decisions that impact the population at large. So let's talk about these decisions in population healthcare. So in population health, decisions are made by organizations and institutions that have a capacity to create change. Because if they don't have a capacity to create change, then their decisions do not matter. They won't be able to do anything about that decision. These decisions influence health outcomes of groups, communities, or entire populations. And the goal is always to improve health and health choices, reduce inequities, and allocate resources wisely. These are the objectives of making decision for population healthcare. So now let's finally come to the crux of how do we leverage big data for making decisions. So we have understood what is data, what is big data. We have understood who maintains this big data. We have understood who uses this big data to make decisions for population health. And we have understood what decisions are. Decisions are understanding a problem, understanding the solution choices, and then making a final selection. So now the best way to understand how to leverage big data is to learn from real world examples. So we will take these four possible approaches. First is we want to focus on the problem. We want to understand the problem. Many a times we don't even know what the problem is, what is the scope of the problem. How do we define this problem? That is one uh, need in itself. The second is what are my solution choices and how will they impact the health? The third is making a selection, selecting an option to act on and to understand what its impact is, and then putting all of this together. So the first is understanding the problem. And within this, you could have four options. One, you want to detect patterns and trends. You want to identify who is being affected and where. You want to quantify the scale and urgency of the issue, or you want to reveal inequities that may otherwise be invisible. These are different ways in which you can leverage big data. You can analyze the big data for these objectives. Of course, there can be many other objectives, but these are the ones that might help you with an initial approach for starting leveraging big data. So, detecting patterns and trends. This is a study from 2020 where measurement of SARS-CoV COVID-2 RNA in wastewater tracks helped understand where outbreak will happen next. So this is an example of a study where they leveraged big data and combined this data from multiple sources, and it helped identify where the next outbreak will happen. So this is understanding the trends, understanding the patterns. And they established that wastewater monitoring was a suitable population level, non invasive surveillance system for infectious diseases. So, this is one example where we detect patterns and trends from big data. The second example, the second option we had for understanding the problem was to identify who is affected and where. So, this is an example of a very nice study where emergency department visits in California associated with wildfire particle size 2.5 differing across risk individuals and communities. So what they did, they combined satellite derived wildfire smoke. This is environmental data and air quality data. And they combined it and they mapped it with emergency department visits to understand when the air quality goes down, what happens to emergency department visits. And they quantified that increases in respiratory emergency visits during wildfire smoke events actually is a serious problem and requires health alerts and resource planning. This is the second example. The next was to quantify the scale and urgency of the issue. So this is another study where global burden of 87 risk factors from more than 200 countries was studied. They integrated national mortality registries across various countries, epidemiological surveys, clinical data sets, modeling to estimate disease burden in quality of life. And they provide the global baseline, which is used by WHO and ministries of various health and donors to prioritize resources and health policy agendas. So this is third way in which we can understand the problem. The last one was to reveal inequities otherwise invisible. So this is again a very interesting study, a very recent study from 2020. Associations between historical residential redlining and current age-adjusted rates of emergency department visits due to asthma in 8 cities. And this study demonstrated that historical housing discrimination, so this is an important problem that we don't otherwise see. There are pockets of residents of different racial ethnicities. And because of certain socioeconomical challenges, there are some environmental aspects of the household, for example, redlining, that impacts the specific community a bit more. And this study demonstrated that this historical housing discrimination is still impacting outcomes even till date. So now, very quickly, I will go back and we understood how do we understand the problem using big data. We could detect patterns and trends. We could identify who is being affected where. We could quantify the scale and urgency of the issue, or we could try to reveal inequities that are otherwise invisible. And we looked at these four studies, and you can go back and read these papers in more detail, and it'll be very useful for you to plan your own uh, uh, analysis plan for leveraging big data. Now I'll go to the next uh, part of our decision making. The first one was to understand the problem. The second is understanding the solution choices that we have, identifying and evaluating solution choices. Here, you could compare different intervention strategies, or you could study how similar problems were handled or solved elsewhere. You could predict outcomes of potential policies, or you could understand community behaviors, beliefs, and barriers. So let's look at a few examples. To compare different intervention strategies. So this is a study where the impact of the Healthy Hunger Free Kids Act on obesity. So this was an intervention that was planned, and this large-scale study actually showed that when this policy was implemented, it was associated with a decline in obesity among children in poverty versus pre-policy trend. So it's an intervention, and they implemented and compared with a few other interventions, and they reported that yes, this intervention actually impacts health outcomes. So it was understanding which intervention would be the most suitable. Study how similar problems were handled elsewhere. This study from 2023, published in The Lancet, they evaluated the impact of alcohol minimum unit pricing on deaths and hospitalizations in a country in Scotland. So they found that increasing the cost actually impacted the outcomes. And these are studies that helps us understand how can we simplify problems, how can we solve problems across different uh, areas. And then you could predict outcomes of potential policies. So beverage purchasing from stores in Mexico under the excise tax on sugar sweetened beverages. So here what they did, that adding excise tax on sweetened sugar beverages actually led to increased water purchases. And the 2-year follow-up study confirmed sustained impacts and improvement in the health behavior and health choices. So these are how do you predict outcomes of potential policies? And then to understand community behaviors and barriers. So this was a very nice study where they wanted to understand the beliefs and uh, behaviors for COVID-19 vaccine related discussion using a social media platform. They did topic modeling and sentiment analysis, and they shared the beliefs and behaviors and barriers to successful vaccination project. What are people thinking? So this is the second part of our decision. The first one to was to understand the problem. Second one was to understand the solution choices. Very quickly, I'll go back, and here it is identifying and evaluating solution choices. So you could compare different intervention strategies. You could study how similar problems were handled elsewhere, or you could predict outcomes of potential policies and understand community behaviors, beliefs, and barriers. So now the next part is the last part, which is the selection. So here you could forecast impact and cost effectiveness, because it's very important. We don't want to know just the best option which works. We want to know which is the best option which will be cost effective when we run it at scale at a population level, how we can forecast impact and cost effectiveness. We could run simulations. For example, we could simulate using a data set what happens if we do this, what happens if we do that. And then you could, of course, evaluate implementation feasibility. Some ideas seem very interesting, but when you talk about their implementation, you realize that they are just not feasible to be implemented. And you could monitor outcomes and refine decisions over time, because not all decisions that are made are the most appropriate decisions. And you also need to continuously adjust your decisions, monitor the outcomes of your decisions, and then decide how do I adjust my decision best. So let's look at a few examples. You could forecast impact and cost effectiveness. This is an example where cost effectiveness of female HPV vaccinations was assessed in 179 countries. This is the prime modeling study. And here they simulated how HPV vaccinations could impact and what would be the cost effectiveness in low and middle income countries when vaccine cost is affordable. And they provided a quantitative evidence used by Gavi and WHO to justify HPV vaccination funding and scale up. And this brings me to a very important uh, 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 use case of big data. So sometimes big data helps us make decisions. So of course there are a lot of important decisions that have to be made by the various stakeholders that we talked about: the government, the hospital systems, the public health agencies. But many a times you want data to help convince others to make the right decisions, and that is very important. So, for example, a simple uh, department of a research institute can leverage big data to publish convincing report on which decisions would be the most suitable. And this can be used for convincing the stakeholders to make a suitable decision. So, big data is not only for the public health agencies or only for the government, it is a democratic resource available to everybody. I can use it, you can use it, anybody can use it. And that's the whole point of having things being open sourced. This big data is being made available to everybody. And everybody, if you follow a certain path for extracting meaning out of this big data, which is reproducible, which is uh, free of errors, which is you have understood the assumptions of the big data, you have understood which population this big data represents, and you are making responsible claims from this analysis, then you can definitely convince even the top level stakeholders to focus on a certain direction. So anybody can use and leverage big data to forecast and show impact and advertise a certain decision choice. The next is to run simulations. What happens if we do this? So this study, a slightly older study, almost 10 years ago, estimation of benefits, burdens, and harms of colorectal cancer screening. What are the various strategies? And they simulated what happens if we have multiple screening strategies across different ages. And this helped guide a very famous national health policy called USPSTF, showing how simulation enabled evidence-based recommendation decisions. So simulation is extremely powerful, and simulation from small data sets is not generalizable. But when you simulate something out of a big data, it is generalizable. It has a lot of meaning. And when you have huge amounts of data, you can do suitable simulation studies. So the next is evaluate implementation feasibility. This is again a more practical aspect of your the impact of decisions. It's very easy to make a decision, but to understand how this decision will it be implementable or not. So this study of genetic identification of familial hypercholesterolemia within a single US healthcare system, and they identified that newly identified familial hypercholesterolemia received treatment intensification and follow-up showing genomics can be embedded in a routine care. So this is feasibility implementation, and they understood the scale. There are 50,000 exomes, and they linked it with the electronic health records, and it's a genome first case finding. So it's a very interesting study where you can understand how implementation feasibility is analyzed. Next is you have made a decision, and now you could monitor the outcomes and refine your decisions over time. So this is surveillance for adverse effects after COVID-19 vaccination, mRNA vaccination. And this study demonstrated the value of linked EHR immunization big data sets to detect rare risks quickly and inform communications. And that's very important. And that's how you can use big data to monitor outcomes. So we have seen the last part, which was selecting the best option. So first you define the problem, you use the big data to help understand the problem, then you identify what solution choices do I have, and you use the big data to identify your solution choices. And finally, you make a selection. And for selection, you could do forecast, impact and cost effectiveness. You could run simulations. You could evaluate implementation feasibility, and you could monitor various outcomes. So we discussed these four studies. And now finally we come to one example where we put it all together. We want to understand the problem, we want to understand the solution choices we have, and then make a selection. And this is how you leverage big data. And you can leverage big data by gaining a better understanding of any part of this decision making. And one very important thing I forgot to mention is that this whole idea of the decision, this comes in from the experts. So population, so from the government, from research institutions, from public health agencies, they have a general understanding of the whole problem. And they leverage the big data to quantify what they are thinking, to make sure that what they're thinking is correct. So you need the domain expertise to leverage this kind of decision making. So let's see an example where we put it all together. This is a older study where improved blood pressure control associated with large scale hypertension program. So they first identified the problem that only 44% of patients had controlled blood pressure across the health system. EHR analysis across 1.5 million patients revealed a system wide gap. That's the problem. What were the solution choices they considered? Different blood pressure measurement workflows, treatment protocols, and a team based care where you have a clinician, you have a dietitian, and you have an additional person for explaining the new behavior the patient needs to adopt. And the EHR allowed simulation of workflow changes plus medication intensification outcomes. And the final is selection and evaluation. They finally selected a standardized treatment protocol plus care registry, which they have discussed in some more detail. And they reported that continuous EHR monitoring showed blood pressure control improved to 80% system wide. And this is how you can leverage big data to quantify uh, your problem, quantify the solution choices you have, and then finally come up with a solution that shows that yes, there has been an impact. So finally, at this time, if you talk about the conclusion of what all we have discussed. So before I conclude, let me very quickly summarize what all we discussed. We started with what is data. Then we said, if this is data, what is big data? And we discussed that big data means there is data from various sources of healthcare, and we combine this data, bring it all together, make sure that this data is safe and we are not harming any identification of patients, and we can use this to derive meaning for better choices. Then we talked about who maintains this big data. Then we discussed who uses this big data. Then we discussed what should we do with this big data. We realized that we need to make decisions. Then we discussed who makes these decisions for health, population, and care. And we identified that these are organizations that have a capacity to create change. And we also discussed that it's not just their responsibility. As researchers, as students, as teachers, we all have a responsibility to best utilize a data set and to help make the most suitable decisions. And let's say once we have understood these decisions, what all ways are there in which we can leverage big data? We could understand what is the problem. Then we could understand what are the solution choices we have. And then we could understand what are the best solutions that we should implement. And then we discussed some examples, and I would highly encourage you to go back and look at a few of these examples that I've shown. But these are just very few examples. There are a lot of other examples in the literature. And finally, here I conclude. So there is so much of data in healthcare now. It's all healthcare data. You have clinical data, you have social data, you have behavioral data, you have environmental data, you have genomic data, and even system logs from electronic health records are being used in analysis now. The challenge is data collection is not a challenge. It may be a challenge in a very specific niche areas of research, but for general disorders, it's not a challenge anymore. The making sense of this data is the bigger challenge, and then using it well is a much bigger challenge than making sense of it. So big data has enormous potential, but realizing that this potential requires governance, it requires interoperability, it requires trust, it requires capacity. And our task now is to translate this data into insight and this generated insight into action for better and healthier populations. And this is where I will conclude, and I'll be very happy to uh, discuss and talk about any questions that our participants have. And I'm not sure if I'll be able to answer questions, but I will definitely be able to discuss them and help refine the question and direct you in a suitable direction. Once again, thank you so much for this opportunity. And I'm grateful to Dr. Susan Fenton for considering me for this opportunity, and the organizers of this event for organizing this large scale event. It's a wonderful session. Thank you.
Okay, thank you so much to Dr. Uday for such an inspiring and eye-opening presentation. Your insights have truly shown us how data can drive better health outcomes. We really appreciate your valuable contribution today. Now, we will move on to the discussion segment. Participant, please feel free to raise your hand or type your question in the chat box, and we will address them one by one. Alright, there's someone who raised hand. from Nashwa Nafisa Nufadillah.
Hi, Nashwa. Please go ahead.
Hi. Wait.
Hi.
Good morning, everyone.
Good
Okay, my
morning.
name is Nashwa, and I'd like to thank Mr. Uday Pratap Singh for the insightful presentation about big data and its role in population health. I truly appreciate how you highlight the importance of ownership, privacy, and actionable knowledge in data. Okay, in here, this is my privilege to asking and talking with you. And I have one question in this question. Wait. I highlight a battery from you. And the question, I have a question regarding the balance between data accessibility and privacy. Give the access big data is often limited by ownership and privacy regulation. Okay, and this question, how can institute effectively collaboration and share data to generate actionable knowledge without compromising ethical standard or individual content? In other words, what practical framework or governance model do you think can help bridge the gap between data silos and the need for integral insight in population health? Thank you for once again for sharing such a thought-provoking perspective. Your talk really inspired us to think beyond the technical side of big data and focus on its social responsibility. Once again, thank you so much.
Awesome. Thank you. Thank you so much for your question. It was a long question, and I'll try to respond as much as I can. So, data confidentiality, interoperability, and making an ethical use case of big data is, of course, uh, the most important aspect of being able to use big data. And it depends, most importantly, it depends on the rules and regulations and how we safely follow various guidelines. So there are a lot of guidelines which are available that help us understand what are the various standards we need to follow when we are accumulating data across organizations. And I would encourage you to um, it's a very challenging process to create a big data set, even within your own department. And if, let's say, we are all students, even within a student group, try a small project where all the students get together and contribute to a data repository. Let us say you have a collection of your favorite movies. Create a small data set of all of your favorite movies, add various details, who is the actor, what is a nice thing about this movie. The first thing that happens is somebody will add some details, somebody will have some other details. The first thing that you need to do is finalize a structure. How are you going to contribute to this data? The second thing is that as we are contributing, we need to de-identify and make sure that this data does not uh, uh, infringe upon the identity of any individual. And there are a lot of very good guidelines, and we have giants who have already solved a lot of these problems. And I would encourage you to this kind of literature to study how do we simplify this important challenge. Yes, thank you for your question.
I got it. Thank you so much, Mr. Uday
Thank you.
Pratap Singh.
Thank you. So
Okay,
there is
thank
a
you for the
question in the
question.
chat. Yes, please.
There's a question in the chat box from Naila Firdausi. Thank you, Dr. Uday, for the insightful presentation. In the context of medical record and health information system, and my question is, what do you see as the most critical step for low and middle income countries to achieve reliable big data integration, considering challenges like interoperability, data governance, and public trust?
So, if you were to ask what is the most critical step for achieving reliable big data integration in low and middle income countries, that's a very important question. I feel that if there is a felt need, then everything falls into place. Let me explain. Um, right now, big data and analysis of this big data may seem like a luxury, may seem, oh, we don't have this data, oh, the data is disintegrated in various institutions. It's all right. We don't need to compile this big data. This is a general opinion in a lot of places. But once you realize that if we have this big data, what all would we be able to achieve? So there are stakeholders, which are the decision makers that help us fund such initiatives, that help us understand what needs to happen. We need to talk about what are the benefits of having a big data set and how it would help us make better decisions. And the moment there is a talk about this felt need, then you will realize very quickly all the resources, all the things that you need will automatically align. So it is a matter of prioritization. And prioritization in a topic like this, where we say that if we have a big data, we can make better decisions, can happen only by learning from examples. So if you've learned from examples from other countries that they have a big data and they were able to make a better decision, then we could also do it. We have a lot of data. And of course, uh, anything can happen only after there is a suitable uh, digitization of data from different institutions. So, based on the limitations of that particular country, for example, I'm from India. India has different challenges, and many countries have their own individual challenges. So, based on those challenges, you could start resolving the challenge. But the critical step is prioritization of this decision to create a big data set, in my opinion.
All right. There's another participant who wanna ask to Alins Amalia Rizky. You can ask your question.
Okay, first of all, thank you for the opportunity to ask question. My name is Alins Amalia Rizky, and my question is that you show how algorithms help decide where to send doctors and medicine. But what if the computer says to close a rural clinic because data shows few people use it? The computer doesn't know that people walk for hours to reach that clinic. How can we make sure computers help make decisions but don't replace human understanding of local needs? Thank you.
Yeah. So that's a very important point, and thank you for that question. So what happens is that big data is definitely suitable for the most general trends. It is suitable for um, generalization, but you are very right in identifying that if the reality is misrepresented in the big data, then the AI or any insights driven from this data will lead to false decisions. So there is a concept of garbage in, garbage out. So if the big data itself is not representing the truth appropriately, then any decision made from that big data will be challenging. This is a very important challenge, and this and a few others. These are important things to keep in mind when we analyze big data. When we get to the point where yes, we can make a decision from this data set, we need to consider such challenges. For example, you talked about a very important point where uh, certain lower activity regions can be misrepresented in big data set. Similarly, the needs of certain racial populations can be misrepresented in big data. Similarly, there is a concept of proxy markers, meaning to say that in US there was a study, there was a metric that was used to understand. They wanted to predict what are the healthcare needs of population, and one of the proxy metrics for analyzing this was how much they are spending. And it was a very wrong proxy in the big data, meaning to say that how much a person is spending in healthcare does not represent their needs. There are a lot of ethnic and racial populations that are not able to spend enough money in healthcare, but their needs are much more than people who are able to spend money. So these are very important challenges that have to be kept in mind when we get to the stage of using big data for making decisions. Thank you for your question.
Alright, thank you to Alins for the question. There's another question in the chat box from Gina. Many hospitals in Indonesia are still in the process of transitioning from paper-based record to electronic system. How can we ensure data quality and consistency during the digital transformation so that medical record can contribute effectively to big data analytics? Thank you.
So, once again, very important question. Thank you for asking this. So, there are various countries, and they are in various stages of their healthcare digital transformation. For example, United States is at a very mature position. They started the digitization almost 20, 30, 30, 35 years ago, and they have been able to digitize quite a lot, but they still have challenges. Countries like United Kingdom, many other more developed countries are in a similar boat, but they still have challenges. Countries like India, Indonesia, they are similarly in the process of digital transformation. The best way would be to use whatever technology we have and learn from the lessons that have been learned by the more developed countries who have already made a lot of mistakes and learned a lot from their mistakes. I would encourage you to look at literatures published by the Institute of Medicine in the United States, and they talked about how digitization has increased a lot of challenges. It is, of course, useful, but they learned a lot of lessons. So, if you were to ask how to ensure data quality and consistency during this digital transformation, one, learn from the lessons learned by other countries that have already completed this journey, And second, when they were doing this, they did not have anybody else to learn from. And secondly, they did not have the kind of technology that exists today. Today, you have ChatGPT, you have more secure, HIPAA compliant, AI based systems as well that can help you with this kind of digital transformation. But the biggest and the most important suggestion will be um, if so, don't so start with digitization today. So the new interactions of patients and clinicians that happen, let's focus on them instead of focusing on the past records and converting them into digital records, because that is a lot of burden and it's difficult to cover. But start when you can and keep on working with the previous records, but start with digitization today and start with whatever digitization tools are available because they will keep on improving. Thank you.
All right. Thank you for this intriguing question and discussion. Once again, our sincere appreciation to Dr. Uday for sharing such a valuable insight with us today. We truly appreciate your contribution. This session highlights the importance of connecting diverse data sources to see the full picture of population health. The key message in the data becomes meaningful only when it informs real decisions. We hope this session has encouraged us to think about using data well, turning insights into meaningful action. We will now present a certificate of appreciation to Dr. Uday.
Thank you.
Everyone, please join me in giving a big virtual applause for Dr. Uday.
Thank you.
All right. Thank you. You may now return to the participant screen as we move on to our next speaker. Ladies and gentlemen, thank you again for the intriguing discussion. Let us now move forward to our next distinguished speaker. It's my great pleasure to introduce Ms. Diana Barsasela, PhD, from Department of Medical Record and Health Information, Tasikmalaya Health Polytechnic, Indonesia. Ms. Diana holds impressive academic credentials. She earned her PhD in Biomedical Informatics from Taipei Medical University, Taiwan, and her Master in Public Health in Health Informatics from Universitas Indonesia. With a strong foundation in biostatistics, informatics, and health information system, Ms. Diana has been a consistent contributor to international research, particularly in areas like machine learning, hospital data analysis, and digital transformation in healthcare. She is an active author and co-author of numerous publications in reputable international journals, including the International Journal of Medicine Informatics and Medicine. Beyond academia, She is frequently invited as a speaker and reviewer for international conferences in the field of digital health. We are truly honored to have her to share deep expertise and commitment to data-driven healthcare innovation with us today. Today, Ms. Diana will presenting on topic Foundation of Health Data and Population Health. Today we are honored to have her share her insight and expertise with us. Please welcome Ms. Diana to the virtual stage.
Okay, thank you for the Master of Ceremony. Can you listen my voice clearly?
Yeah, I can listen it clearly.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
It's an honor to be and happiness to be here at the International Seminar of Health Information Management 2025. Today, I'll be sharing insights on foundations of health, health data and population health. So together, let's explore how data can guide better decisions and improve preventive care for healthier communities. Okay. I think the operator can share my PPT slide presentation. Committee, please share my PPT slide presentation. Thank you.
The commit to share your screen. A quick time management reminder for your session. You will have 45 minutes for your presentation, followed by a 15-minute for discussion. I will help you manage the time effectively.
Okay, thank you. So we are still waiting for the my slide presentation to pop out. We are waiting the committee, okay?
All right. All right. Miss Diana, the presentation is all ready. Now you can share your presentation.
Okay. Yeah, thank you. My topic today is from data to decisions, the foundations of health data and population health. Actually, this is the basic one, but and should be delivered before Dr. Uday. But because in USA now is we have 12 hours gap, so we change the time to present. Next. Okay, the agenda for my presentations today will be introduction, definitions, and then population health, and then determinants, a data source, the standards, big data, analytic spectrum, until we will have the conclusion and the next step. Next. So we are talking first about what is the population health. Population health is focusing on the overall health outcomes of a defined group of individuals, including the distribution of those outcomes within the groups, such as community, region, or even nation. Unlike clinical medicines, which centers on individual patients, population health examines patterns, causes, and effect of health conditions across the groups. So the goal is not only to improve the average level of health, but also to reduce disparities among different segments of the population. In other words, the population health can emphasize both overall improvement and fair distribution of health outcomes. So the key components we will have is the first is outcomes, and then distribution and determinants. So when we talk about the outcomes, health outcomes refer to the measurable results that describes the health status of a population. The common indicator can be or include the mortality, morbidity, and quality of life. With the mortality about the death rates, life expectancy, and then and leading causes of death, and then morbidity. We will talk about incidence and prevalence of diseases, disabilities, and chronic conditions, and then quality of life, about how people perceive their physical, mental, and social well-being. It often measured by using the tools such as the health-related quality of life, HRQOL. So, and then the second one for the key components is a distribution. The components looks at how health outcomes vary among subgroups within the population. For instance, life expectancy or disease prevalence may differ by age, gender, socioeconomic status, and then ethnicity, geographic region, or education level. Then determinants, health outcomes also shaped by multiple determinants of health, and it is often grouped into several domains like social factors, environmental factors, economic factors, and behavioral factors. From the social factors related to education, employment, social support, and community safety. Environmental factors like air and water quality, housing, and urban design, and then exposure to pollutants, and then economic factors, it can be related to income, health insurance coverage, and access to nutritious food. And also for the behavioral factors can related to lifestyle habits such as diet, physical activity, or smoking, and alcohol use. And then these determinants interact dynamically. For example, low income may limit access to healthcare and healthy food, and it can influence also the morbidity and mortality. Next. Okay. Next. No, previous one. Okay, previous one. Yes, this one. Next, we talk about the social determinants and equity condition that can influence the health will be consisted from several things. First is where people are born, grow, live, work, age, and access to money, power, resources, and education, and housing and employment. When we talk about where people are born, grow, live, work, and age, this is will be included the birth and early childhood, the childhood born into poverty or malnutrition are more likely to experience poor growth and chronic diseases later in life, also maybe such as stunting and etc. And then for the also living condition, workplace environment, and aging. And the second one is access to money, power, and resources. Money allows people to buy nutritious food. Even power enables individuals and communities to influence the policies and systems that affect the health. Also, the resources include community infrastructure, transportations, and healthcare services. And education, the higher education levels correlate with better health literacy, etc. Next. We have several population health metrics here. The first is mortality and life expectancy. The mortality refers to the number of deaths within a population over a specific period. It includes crude death rate. Crude death rate is total deaths per 1,000 population per year, and then cause-specific mortality rates. Deaths due to a particular disease or condition, such as cardiovascular mortality, and then infant and maternal mortality rates, the key indicators of health systems, performance, and social conditions. And another metric is about the incidence and prevalence. The incidence is the number of new cases of the disease during a specific period among a defined population at risk. For example, the incidence rate of dengue fever per 100,000 people in 1 year. And then prevalence is the total number of existing cases at a certain or given time. For example, the prevalence of diabetes or hypertension in adults. So by comparing incidence and prevalence, public health experts can differ or can distinguish short-term outbreaks from chronic, long-lasting conditions. And then another one is daily and Kelly. This one is the summary measures of the population health. Daily, DALY, stands for disability adjusted life year. It represents the total years of healthy life lost due to premature death or disability. And then, for example, if a population has many deaths from the stroke or a long-term disability from diabetes, so its daily will be high. And then Kelly is a quality adjusted life year, measures the quality and quantity of life gained from healthcare intervention. 1 Kelly equals 1 year of life in perfect health. So, and then another metric is risk factors. Risk factors classified into three domains: the behavioral factors, and then environmental factors, and then socio-economic factors. For the behavioral factors, it about the lifestyle choices such as smoking, alcohol use, and then unhealthy diet and physical inactivity. Environmental factors will be related to air and water pollution and something related to environment. And then socioeconomic factor will be related to poverty, unemployment, low education, and lack of access of healthcare or social protection. Next. Now we are talking about the essential public health services, can be shortened with by EPHS. EPHS framework defines the core functions and responsibilities of the public health system, and the framework consists of 10 related services. So these 10 services, it can be grouped into the three core functions of public health. Actually, the first can be included into the assessment. So for the assessment and monitor population health, and this is about collect, analyze, and interpret data on health status, risk, and needs of the population. And then second one is investigate, diagnose, and address health hazards. In this group, we detect and respond to the health threats such as infectious diseases, environmental risks, and occupational hazards. And then I think the fourth one is strengthen. We can see this one, strengthen community partnership. So if we check one by one after we group, then we check one by one from these 10 essential public health services. So the fourth one is strengthen community partnership. It is about collaborating with community organizations, school, NGO, and private sectors. And the five, create and implement policy and plans. And we develop public health policies, strategies, plans, and based on evidence and community. And then another one is use legal and regulatory actions, which consists of enforce laws and regulations to protect health and ensure safety. And next one is ensure equitable access to care. We guarantee that everyone has access to quality health services regardless of socioeconomic status or geography. And the eighth one is build a skilled public health workforce. Here, we recruit, train, and retain competent public health professionals. And also, next is improve and innovate functions through evaluation and research. And then the last one is maintain a strong organizational infrastructure. Next. Okay, this is data sources and ecosystem. The population health relies on a diverse ecosystem of data sources that together capture the medical, behavioral, social, and environmental determinants of health. The first one, from the electronic health records. Electronic health records is the digital versions of the patient's medical chart maintained by hospital, clinics, and healthcare provider. So, for example, hospital information system in Indonesia capturing inpatient and outpatient data. And then another source is from claims and insurance, the administrative data generated from billing and reimbursement processes. For example, the National Health Insurance or JKN data used to monitor utilization trends and identify inefficiencies in hospital claims. And another is from the public health surveillance. The continuous systematic collection and analysis of health-related data for planning and response. For example, Indonesia's Sistem Kewaspadaan Dini and Response (SKDR) for the communicable disease monitoring. And then socioeconomic and environmental data. This is related to the data describing the social, economic, and environmental context that affecting the population health. For example, the linking health outcomes with data from BPS, Badan Pusat Statistik, or environmental monitoring agencies. And then another one is behavioral and lifestyle data. It's about information on individual or group behaviors influencing health status. So, for example, Riskesdas, Riset Kesehatan Dasar, Riskesdas is national surveys on lifestyle behaviors. And then another one is wearables and remote patient monitoring or RPM. This is about digital devices and sensors that continuously capture physiological data from individuals. For example, a smartwatch, and then fitness trackers, IoT, Internet of Things, based health devices, which is integrated into a clinical monitoring platform. And another source can be from the genomic and omics data. This is about high dimensional biological data that reveal genetic and molecular determinants of health and disease. For example, the genomic databases or biobank, which is integrating patients' label genomic and clinical data. Next. Now we are talking about the interoperability and standards. It is very important currently. Interoperability refers to ability of different healthcare systems and then software applications and devices to exchange, interpret, and use data across organizational and technical boundaries. So it ensures that health information follows the patient regardless of where care is delivered, like hospital, clinic, laboratory, or telemedicine platform. And it will be also related with the FHIR when we are talking about the interoperability. FHIR stands for Fast Healthcare Interoperability Resources. Is modern HL7. HL7 is a health level 7 standard designed to enable efficient and secure electronic exchange of healthcare information using the modern web technologies. So it combines the best element of HL7 version 2, version 3, and CDA. CDA is the clinical documentation, and then promotes API based data access. So, but such as a RESTful API, or maybe API stands for Application Programming Interfaces, and JSON or XML data formats. Um, the the benefit of the FHIR, the first is real-time access to quality data and reduced reporting burden. So when the clinicians and administrators can access patient data instantly from multiple sources, this is the one of the benefit. And then another is reduces manual data entry, and then improve the accuracy of health information for decision making. And the second one is the benefit is aligned clinical decision support and quality measurement. Uh, uh, it, it enables integration of decision support tools like a drug interaction, and then treatment recommendation directly into clinical workflows. And also the standardized data structures can improve benchmarking and quality assessment across facilities and regions, and supports the analytics and population health dashboards. And then the last benefits is promotes interoperability through RESTful API. The RESTful API will be allowing the different systems such as the hospital electronic medical records and the mobile health apps and national databases to connect and share the data securely, and then facilitates interoperability at scale. It can promote coordinated care across the primary, secondary, and tertiary levels, and encourage innovation by allowing new digital health tools such as telehealth apps, AI-based analytics to connect easily with existing systems. Next. For this part about defining big data in healthcare, actually it has discussed by Dr. Uday. So I will be deliver in short only because he has talked more about the characteristics of big data in the healthcare. The first one is volume, velocity, variety, and veracity. So the volume is a large data set from for example from EHR, and then velocity is continuous streams from real-time sensors and wearables, and variety is structured and unstructured data, clinical notes, images, social media, and veracity about ensuring the data quality, completeness, and consistency. Next. Now we discuss about the analytic spectrum. The three main stages of the analytic spectrum are consisted of these three. The first one is descriptive analytics, and then predictive analytics, and then prescriptive analytics. So when we are talking about the descriptive analytics, it will focus on summarizing and interpreting historical data to identify the trends, patterns, and relationships. For example, we analyze the 5 years of EHR data to determine the rise in diabetes cases, or identifying which hospital departments have the highest patient visit. And another spectrum is predictive analytics. Predictive analytics uses the statistical models, and then uh, machine learning and AI to analyze current and historical data in order to forecast the future outcomes. For example, early warning system, which can detect the potential outbreaks or patient deterioration in ICUs, and then a predictive model using patient vitals and lab results to forecast which patients are likely to experience sepsis within the next 24 hours. And then the last one is the predictive analytics. Predictive analytics builds upon the predictive insights. So by recommending the best course of the action to achieve desired outcome. For example, an AI system that recommends specific preventive measures or treatment adjustments for diabetic patients to reduce the complication. So it's like the continuous from the predictive. So we call it by prescriptive analytics. And then next. From the market growth and adoption, we can see it will be increase year by year, and will be very higher on the 2033. So the use of wearable health technologies such as the smartwatch, fitness tracker, and then biosensors, and then smart patches has grown threefold in just 4 years. Yeah, you can see, reflecting a global shift toward continuous and personalized health monitoring. And next. Wearable and remote monitoring. The first is continuous monitoring and patient engagement and integration. So continuous monitoring, such as we can use the smartwatch or wearable devices, such as smartwatch, fitness tracker, biosensor, and medical patches, which allow continuous and real-time monitoring of vital signs of physical activity and behavioral patterns. For example, the continuous glucose monitor, CGMs, that send alerts to both patients and clinicians when glucose levels become unstable. And then the second one is the patient engagement. Also, the wearable device and mobile health application empower patients to become active participants in their own care. How it works? Individuals can track their daily activity, sleep quality, stress, and nutrition using mobile apps linked to wearable devices. For example, the hypertensive patients using home blood pressure monitor sync with smartphone apps to share reading with their doctor. And the last one is integration. Integration is the process of connecting wearable data with electronic health records and analytics platform to generate the applicable or actionable insight. It works that data from the wearable automatically send or flow into hospital systems or population health dashboards via secure through the secure API such as a Fire. For example, a smartwatch send the abnormal health rhythm data to hospitals EHR, which is triggering cardiology follow-up alert. Next. Another one, we are talking about the predictive analytics and machine learning. The predictive analytics uses the statistical models and machine learning algorithms to analyze the historical and current data in order to anticipate the future outcomes in healthcare. This means using data to forecast risk, resource needs, and clinical outcomes. The machine learning can enhance this process by automatically identifying.
Miss,
Yes.
a reminder, the time for presentation is 10 minutes away. Thank you.
Okay, thank you. Okay, thank you. 10 minutes, yeah. Machine learning can enhance the process of predictive analytics by automatically identifying hidden patterns and correlations in the huge data sets from electronic health records, wearables, laboratory results, and public health sources. Okay, next. And then telehealth and hospital at home. This is, for example, for post-pandemic expansion. Telehealth refers to the delivery of healthcare service using digital communication, such as the video consultations, mobile apps, and remote monitoring. And during COVID-19 lockdowns and physical distancing made virtual care essential. And then for post-pandemic reality, also it providing convenience, accessibility, and cost efficiency. And for the integration challenges, the interoperability and data flow across the platform such as the telehealth, EHR, remote monitoring system, and hospital databases often operate in the silos. And then for the clinicians' cognitive burden, in this modern digital care, clinicians face data overload from multiple monitoring devices, sensors, and electronic records. And another challenge is need for reimbursement and coverage parity. Without parity, healthcare providers may hesitate to sustain or expand virtual care programs. And next. Also about the data quality and integration, we have so many challenges. The first is the fragmented systems and interoperability gaps. The healthcare data is scattered across multiple systems such as EHR, laboratory system, pharmacy records, insurance databases that use the different formats and standards. For example, a patient's hospital record may use ICD-10 codes, while a community clinic uses free text diagnosis and preventing automatic data exchange. So the solution, it could be implement the interoperability standards such as HL7 and FHIR, HL7 FHIR, and then national health data exchange to enable seamless communication across system. And then missing or inconsistent data values, this is another challenge. The data may be incomplete or outdated and inconsistent due to manual entry errors or differing collection methods and the lack of standardized coding. And then the solution apply data cleaning and validation routines, and also use standard terminology such as SNOMED, LOINC, and ICD, and then implement real-time data quality checks within in the EHR system. And then privacy concern and governance concerns. As healthcare data grows in volume and sensitivity, protecting patient privacy and data security becomes more complex. And the last challenge is needs for skilled data scientists and informaticians, because for transforming raw data into the actionable insights requires expertise in data science, epidemiology, health informatics, and machine learning. Next. This is for data breaches and privacy. The healthcare organizations are facing a significant and growing cybersecurity crisis currently. The sensitive medical data such as a patient's record and insurance information and genomic data is highly valuable and increasingly targeted by the cyber criminals. Next. Okay. Also, when we are talking about the ethics and equity, ethics and equity become a central to healthcare are digital health, big data, and artificial intelligence. These are very crucial to ensure that technology benefits everyone fairly. So ethical data use goes beyond compliance. It focuses on transparency, fairness, and then accountability and respect for human rights. So, for example, for responsible use of data, example, a predictive tool for heart disease trained mainly on data from men might underdiagnose a woman with the same condition. And then another example, or another challenge for the ensure fair access to digital tool is digital divides such as a lack of connectivity, language barriers, and low digital literacy. Next. This one is big data in public health practice. The applications like the outbreak detection and real-time surveillance, the big data allows health system to detect disease outbreaks early through continuous monitoring of multiple data stream. And for the modeling disease spread and forecasting, also big data analytics supports epidemiological modeling, helping scientists and policymakers to simulate how a disease spread through the populations. And another, like evaluating program effectiveness and resource allocation. For example, using the health insurance claim or EHR data to assess the effectiveness of chronic disease management program. And the last one, engaging communities and partners through data-driven insights. For example, sharing neighborhood level data on air quality, vaccination coverage, or vector-borne disease risk to promote public participation. Next. This is the big data pipeline from ingestion, integration, storage, analytics, and decision. So a robust pipeline can orchestrate data from source to insight, ensuring quality and interoperability. Next. Yeah, this one also Dr. Uday had discussed about the machine learning use cases. So I will only deliver in short the medical imaging, for example, detect tumors, fractures, anomalies faster and more accurately, and risk predictions, stratify the populations for diabetes, sepsis, and readmissions, yeah, and then triage and decision support. AI chatbots and assistants help clinicians prioritize and coordinate care. Next. The population health management tools, such as dashboards and registries, as centralized data visualizations and tracking system for population level health management. For example, visualize metrics and track cohorts across time. And another is risk stratifications and alerts. Uses the data to analyze or to predict modeling to categorize patients by their level of health risks, such as a low, moderate, and high risk of hospitalizations or complications. And then another is care coordination. The care coordination tools facilitate the integrated care plans, ensuring that each patient receives the continuous holistic care across different settings. For example, integrated plans link providers, payers, and community services. Next. This one is integrating social determinant of health, SDOH. Why? Because many health outcomes are driven more by social factors than clinical care. And then the data on housing, employment, and education identifies at-risk population and enables targeted interventions addressing root causes. Next. Also, this is the strategies for equity to address the inequities. The first is improve daily living conditions, like housing and education, employment, and then tackle the inequitable distribution of power, money, and resources. And the third one is measure and monitor outcomes to assess impact. The data-driven policies must be complemented by community engagement and social investment. So the achieving health equity requires the integrating social action, policy reform, and data analytics. When the evidence meets empathy and data meets dialogue, health system can truly transform, ensuring that every community thrives, not just survives. Next. This one is policy and regulation. So the first one is HIPAA. HIPAA sets standards for privacy and security in the U.S. HIPAA stands for Health Insurance Portability and Accountability Act. HIPAA establishes national standards for the privacy, security, and confidentiality of the patient's health information in the United States. And another is the GDPR. GDPR in the European Union. GDPR stands for General Data Protection Regulations. GDPR governs the collection, processing, and storage of personal data, including health information within the European Union. And then local laws and data governance policies vary worldwide, including Indonesia. And then for the policy consideration, the crafting effective data policies requires balancing two critical goals like innovation and protection. And then balance innovations with the protection, enable data sharing while ensuring consent and equity. Next. Workforce and capacity. So a multidisciplinary team is essential. The first is data scientists and analysts, and then epidemiologists and public health experts, and then clinicians and informaticians and community advocates and policymakers. They invest in education, training, and retention to build a sustainable data-driven workforce. Next.
I'm sorry to interrupting, but the presentation session is over. To keep everything on track, now it's for discussion segment.
Okay, thank you. Actually, this is the last page about the value and realization. So before I close the presentation, let me give the conclusion. The conclusion is the population health requires the comprehensive and high quality data, and then the big data and analytics empower preventive and personalized care. And then for the ethical, equitable, and secure practice are non-negotiable, because this is very important. And then interdisciplinary collaboration and continuous learning are vital. Okay, thank you. I'm giving back to the Master of Ceremony.
Thank you so much to Ms. Diana Barsasela for such a thoroughly insightful and detailed presentation. Your expertise in integration health informatics with real-world health system is truly inspiring. We really appreciate your time and valuable contribution today. Now, we will transition to our discussion segment. We welcome questions from the audience. Participants, please feel free to raise your hand or type your question in the chat box, and we will address them one by one. All right. There are a question from Salsa Nuradila.
Thank you so much. Good morning, ladies and gentlemen. My name is Salsa Nuradila, a fifth semester student majoring in medical record and health information from Poltekkes Kemenkes Tasikmalaya. Especially, I'm very interested in the foundation of health data, especially in the national context. I would like to ask a question regarding the Satu Sehat initiative. How can we guarantee that data standards are used consistently and accurately in all healthcare facilities from puskesmas to hospital? Furthermore, what kind of data quality assurance mechanism would be the most effective and sustainable to implement routinely? Thank you.
Okay, Miss, you can answer the question right now.
Okay. I think we talk more about Satu Sehat with Salsa, yeah, more and more times, even outside this discussion as well. So Salsa discussed that how to guarantee the data security, right, through the routine implementation. So uh, actually, before we are talking about Satu Sehat, we have the two big data in Indonesia, which is not interoperated nowadays, yeah, currently. So Satu Sehat and JKN, yeah. So for example, in Taiwan, they only have the one health data in Taiwan. They only use the insurance health national health insurance NHI. Yeah, so only one big data interoperated, which is interoperated from all of the healthcare providers in Taiwan. So we hope maybe one day in Indonesia we can also have only one health data. Yeah. Actually, it is okay to have so many health applications. But the important thing is about we are talking about interoperability. So how we can guarantee the data security in Satu Sehat, ya? Initiative by implementing routine, structured practices at both the system and institutional levels as well. So we are not talking about system only, but also we are talking about the institutional level, such as the first maybe about the routine data backup and recovery. So regularly back up all the health data to secure servers or cloud storage. It can ensure that information remains safe even if technical failures or cyber incident occurs. And then the second one is a routine access review. So we conduct the periodic reviews of user access rights to ensure that only authorized personnel can view or modify the sensitive patient's data. And then the third one is routine system updates and patching. Keep all the software, including the electronic medical record system and FHIR API, updated to close security vulnerabilities and comply with Satu Sehat standards. And the fourth is routine security audits and log monitoring. Perform the regular security audits and analyze system logs to detect unusual activities early. And then routine training and awareness. This is very important for the especially for the staff. Continuously educate the health staff and students on data privacy, cyber hygiene, and ethical data handling. Okay, maybe every time we talk about this matter with Salsa. Thank you, Salsa. Do you still have any other to discuss?
Maybe that's enough, Miss. Thank you so much.
Thank you, Salsa.
Okay. There's a question in the chat box from Nabila. Ma'am, I would like to ask a question. Since evidence shows that health outcomes are heavily shaped by social determinants rather than clinical care alone, why it's crucial to integrate social determinant of health data into big data system? And in what way can this integrated data help identify priority population and better target effective intervention?
May I know from who the questions?
From Nabila Rahmaniar in the chat box.
I need to check first. On this one. Mom, I would like to ask a question. Since evidence shows that health outcomes are heavily shaped by social determinants rather than clinical care alone, Why is it crucial to integrate social determinants of health, okay, into big data system? And in what ways can this integrated data help to identify priority population and better target effective better target effective intervention? Okay. Okay. Thank you for your question for Nabila Rahmaniar. Okay, that's a very important point. Yeah. Okay, you are absolutely right. The research consistently shows that clinical care accounts for only about 20% of health outcomes, and while the remaining of 80% is influenced by the social determinants of health, SDOH, such as education, income, environment, housing, and employment and social support. By integrating the SDOH into the big data system, is very crucial because it helps us understand the real context behind people's health. For example, uh, uh, two patients with the same diagnosis may have the very different outcomes if one lives in a clean environment with strong social support and another one uh, uh, faces the poverty or unsafe housing. When SDOH data are combined with clinical and behavioral data, we can identify the high-risk populations and then design preventive intervention and then also support equitable health policies. And another question is, and in what ways can this integrated data help? Uh, uh, okay, this is also the important question. Yeah, when we integrate the clinical data with the SDOH and behavioral data, we can move more simply describing health to actually predicting and targeting it. So this, for example, combining hospitalization records with income and housing data can show which neighborhoods experience higher asthma rates due to poor air quality. And then, for example, linking school attendance, nutrition data, and then local food availability can highlight children at risk of malnutrition or obesity. And integrated data transform public health from the one-size-fits-all approach into a data-driven, equitable strategy that, uh, uh, of course, can improve population well-being. I think that's all for the question from Nabila Rahmaniar. Thank you.
Alright, there's another question from Fradifa Anindya. Thank you for the insightful presentation. With your permission, I'd like to ask a question. In the context of implementing big data and predictive analytics in public health, how can we ensure that data analysis results are truly used to reduce health disparities among social groups rather than reinforcing inequalities caused by data bias or limited digital access in the field? Thank you.
So long question. Okay, thank you. Um, from this, how we can ensure that data analysis results are truly used to reduce health disparities among social groups rather than reinforcing inequalities caused by data bias or limited digital access in the field. Mm. Um, I think to ensure data truly reduces health health disparities rather than worsening them. We must focus on the three key principles. The first is inclusive data representation. So the data collection must include populations that are often underrepresented. Yeah. For example, like rural area, lower socioeconomic group, and marginalized communities. And then another key principle. Second one is bias detection and ethical data governance. So before use the predictive models, data sets should be tested for sampling bias or algorithmic bias. Public health institutions need ethical review frameworks to assess whether data used might unintentionally discriminate by gender, location, and income. And the last principle is bridging the digital divide. So we must strengthen the digital access and literacy, uh, uh, which is ensuring communities have equal opportunity to benefit from digital health tools and data-driven programs. I think that's all for Pradiva Anindya Fitri. Thank you.
Okay, Miss. There is another question from Diara Nursifa. Miss Diana, I would like to ask a question. In the context of ethics and equity, explain how the use of biased historical data can cause machine learning to amplify bias in algorithms? And what are the implications of this bias for the principle of equity in access to digital tools?
In the context of historical data, can cause machine learning to amplify bias in algorithm, and what are the implications of this bias for the principle of equity in access to digital tools? Yeah, this is also the long question. Okay, thank you. Actually, this question is also very important question. We are talking in the context of ethics and equity. Yeah, equity. Biased historical data can indeed cause machine learning. Sorry, I'm listening the feedback there. Hello? Okay. Hello? I'm still listening the feedback. Okay, yeah, it's okay now. In the context of ethics and equity, biased historical data can indeed cause machine learning systems to amplify inequities rather than reduce them. So if the data used to train an algorithm reflects past social or systemic biases, for example, underrepresentations of rural patients, women, or lower income groups, the algorithm will learn and reproduce some patterns, the same patterns. This means it may make a less accurate prediction for underrepresented population or even prioritize resource allocation. And then, for instance, if past health service data mostly came from urban hospitals, A machine learning model might conclude that rural communities have lower disease risk simply because their data was missing, not because they are actually healthier. So this creates algorithmic bias where technology unintentionally deepens inequality. The implications for equity in access to digital tools is serious because those already disadvantaged may receive fewer digital health resources or less accurate recommendation, and decision-making system could favor groups that are already well represented in data, widening the digital divide. So to prevent this, we must first use diverse representative data set across geography, gender, and socioeconomic groups, and then continuously audit algorithm for bias and transparency, and then apply human oversight to interpret the results ethically, and the last one is promote equitable access to digital health technologies for all populations. Okay, thank you for Tiara Nurshifa.
Alright. Thank you to Ms. Diana Barsasela to answer all the questions. This session is over, and once again, our sincere appreciation goes to Ms. Diana Barsasela for sharing such a profound insight with us today. We will now present a certificate of appreciation to Ms. Diana Barsasela. Everyone, please join me in giving a big virtual applause for Ms. Diana Barsasela. Alright, thank you, Ms. Diana. You may now return to the participant screen. With this, the session is officially concluded. Thank you for your active participation. Now, we are excited to move on to our third speaker of the day. It's my great pleasure to introduce Nursing Chulalongkorn University, Bangkok, Thailand. Grown from Indonesia. Having earned his Doctor of Philosophy and Master in Science in Nursing from Taipei Medical University, Taiwan. His research expertise is highly focused on adult and gerontological nursing, diabetical education, and evidence synthesis through network meta-analysis. He has made significant contributions to high-impact journals such as The Lancet and Diabetes, Obesity, and Metabolism. Dr. Debbie is an active speaker and researcher in both Indonesia and Thailand, focusing on the use of digital assistant intervention to improve patient outcomes. We are delighted to have him with us today. Dr. Debbie, are you already in the Zoom meeting?
Hello, Tasikmalaya. Good afternoon, everyone.
Well, good afternoon. It's wonderful to have you here. It's so great to
Yeah, thank you
connect.
so much as well.
Yeah. So, do you have anything to tell before we start?
I think it's okay. It's okay for now.
Alright. So, quick time management. You will have 45 minutes for presentation and followed by 15-minute discussion. I will keep an eye on the time for you.
Okay. Okay, let me share my. Could you see my materials clearly? It's okay. The moderator is okay for my PPT.
It's okay.
Oh, it's
Yeah,
okay.
I
Thank
can
you
see
so
it
much.
clearly.
Okay, thank you so much. Good afternoon, everyone. Firstly, I would like to thank you very much to Poltekkes Tasikmalaya and the organization from Medical Record and Health Informations for inviting me again to Tasikmalaya to discuss about the health informations. Since my background that you mentioned in my curriculum vitae that my background is nursing and diabetes educator as well, so I'm focusing on diabetes management and diabetes research and also the health information, of course, according to the specific area which is diabetes management. And this opportunities is about international seminar on health information management. So I will focusing on diabetes preventions. Since diabetes case right now is huge even in Indonesia. So I think Indonesia is top five as well. I will uh, discuss with you also the prevalence of diabetes in Indonesia. So today I would like to discuss with all of you about the clinic's record for two community insights. So strengthening diabetes prevention through quality health informations. And since we have to talk about diabetes prevention and diabetes management or diabetes knowledge, so we have to update our knowledge as well. So this slide is I have to provide the updated or the latest one for the diabetes atlas, which is the 11 edition of diabetes atlas. You can get it for free in the internet or in the Google. So if you in the future or in your thesis or if you focus on the diabetes management or diabetes preventions, even right now you are medical record also have information. I think you have to update knowledge as well. So you can take a look this guideline to update your knowledge and mindset about diabetes knowledge. And as mentioned before, diabetes case is huge even in Indonesia. So I will talk the prevalence around the world first. So diabetes is a major health issue that have reached alarm levels. The 11th edition confirmed that diabetes is one of the various global health emergencies of the 21st century. So let me talk firstly the prevalence around the world that the prevalence of diabetes 2024 will increase dramatically 45% in 2050. And not only so, if we break down around the region, so the Europe, North America, Caribbean, and we focusing on South Asia as well because we live in South Asia. You know, the increase the case from 2024 is 73% in 2050. So it's huge. As a healthcare professional, not only nurse or clinician, also medical record and information student, we have to focus on this case as well. So that's why I'm feeling so glad that you have provided this you provide this good conference. So we talk about good health information and also how the medical record students can contribute to this diabetes prevention or diabetes management as well. And let's move to the Southeast Asia region or CIE, so prevalence of diabetes. We have to know that type 2 diabetes is the most common type of diabetes, accounting for over 90% of all diabetes worldwide. And if you maybe if you're new in diabetes world, but you have to know that diabetes has several types, which is type 1 diabetes or type 2 diabetes. Right now we have type 5 diabetes as well. So basically the diabetes has 5 diabetes, but the most case of those type is type 2 diabetes for over 90% of all diabetes worldwide. And let's take a look about the Indonesia, the prevalence of the diabetes in Indonesia. That this is also, I got this data from the 11 Diabetes Atlas. That is the top 10 countries or territories by number adult 20 until 70 9 years with diabetes in 2024 and 2020 in 2050. And let's see, I mentioned before, like Indonesia always in the top 5 in diabetes cases. So that's why as health professional, this matter to take note that our mindset, we have to contribute to reduce and to control this disease in Indonesia. And today we will talk about diabetes prevention, and prevention efforts often fail not because of lack of technology. So this is kind of the factor, but because health information is fragmented, incomplete, or delayed. As a medical record students and health information, you have to know this issue. So I had experience doing clinical practice in the puskesmas or in the primary health care in Indonesia. So you have to take note that when you in the future when you're working, you have to look at what is the problem in our place. So when I've noticed that in the maybe 5 years ago, the health information is really fragmented and delayed and also incomplete. So it's why this issue I have to rise to yours, to all of you, that you have to know this issue in the primary health care settings. And let's move to the role of health information system. So medical record are the first as most reliable data source for identifying risks, tracking trends, and evaluating prevention outcomes. For those three, I think tracking trend is really important. You have to really do, I think you have to do literature review, what kind of tracking trends in medical records era. And if you're talking about diabetes prevention, so we have to do the high quality criteria. So high quality data criteria is the first one is early detection of prediabetes. So you have to think about this in the future, and not in the future. I think for now, I think you have to learn about the early detection of prediabetes and monitoring HbA1c. HbA1c is the primary things in diabetes, which is glycemic hemoglobin and weight trend as well. And tracking attendance in diabetes prevention, in diabetes education on the lifestyle programs. And the last one is identify gap in the follow-up care. So those 4 things, I think as a medical record student, you have to know, I think this issue is happen right now in diabetes management or in diabetes prevention. So especially the follow-up care or the non-adherence or non-compliance for the patient with diabetes. So as a medical record student, you have to show the data to the healthcare professionals such as nurse or clinician or diabetes educator. You have to know, you have to prove with data to show that this is not good for patient with diabetes. So, and we have to find the solutions. And when these records are integrated and standardized, they become the foundation for population level analytic and the big data. It's called big data is the preventive care is matter. And why the first one I mentioned, but early detection of diabetes matter. Right now, this is my paper that just published in the Q1 journal, that the prevalence of diabetes in undergraduate students is around 21.4%. I think this is 70 of participants from the 322 undergraduate students in Indonesia. So from this phenomena, we have to take note that the pre-diabetes in young generation also the prevalent right now. So you have to, I think you have to show the data and how to provide good data to do the early detection of prediabetes. And this is why this matter to nurse, diabetes educator, and medical record officer. So nurse, educator, and medical record officer are the gatekeepers of data quality, especially all of you guys. And every accurate blood glucose entry, medication update, and patient follow-up note contributes to the preventions. And good health information transform daily documentation into clinical intelligence that support. The first one is the patient-centered decision and resource allocation for high-risk groups and evidence-based community programs. I think for those three, personally, I do. You have to take in your note about the importance of evidence-based community programs. Right now, in the primary healthcare or in the post cases, I think when I based on my experience, most of healthcare professionals is lack of evidence-based community programs. So in right now it's 2025. So before you say, before you conducting health education, or before you provided data, or you to do the commentation of your data, you have to read the evidence-based as well. So evidence-based community program is always important to support your program in the healthcare settings. And clinic records from two community insights. So the first one is the journey from the clinic level documentation. So of course you have to do the community level prevention begins with trustworthy information. So the concept of trustworthy information is always crucial. And when the records are clean, complete, and shared across level of care, they enable the first one is data-driven community programs. For example, like you have to map the obesity case, or you have to provide the data about the prediabetes hotspot as well. And with the data, if the data are clean, also we can enable policy alignment with the real population needs. And the last one is empower communities that understand their own health risk as well. So the last one, I think the crucial one. So when your data about the clean and complete, of course you can empower communities, not only the patient, their family as well, to understand their own the health risks in the community. And I have to say this is also the good concept as well, about the strong prevention begins with strong informations. I think it's your job, so you have to you have to provide high quality information as well. And every accurate record today is the prevention decision tomorrow. I think this is also the good concept as well. And let's move about turning data into action for diabetes preventions. So every clinic visit produces valuable information such as glucose level, weight, medication, and lifestyle note. So as a medical record student, you have to know the important thing in diabetes prevention. The first one is, of course, controlling blood glucose level. I think this is the primary thing for investigating whether the patient is successful or not successful in conducting their own diabetes management or their own diabetes habits. Of course, you have to look up the data from the blood glucose levels, such as including SpA1c or fasting blood glucose level, or another such as cholesterol, or another term about the blood pressure as well. And not only focus on the primary clinical outcome, of course, from the appearance, we have to provide as well the weight, also the drug medications. I think the type of medication also important. And recording the medication right now, I think I'm not really expert how you do the record the medication. However, I understand that the recording medication in diabetes is quite challenging, because in diabetes medication, a lot of type of diabetes from the oral hyperglycemic agent, also from the insulin regimen as well. So you have to talk on how you can provide the good data from the medications. And the last one is lifestyle notes. Also, this is important in supporting the data. And when they properly collected and standardized, this data create a continuum information. I think I just know the concept of continuum information is matter in medical record and information as well. And you have to take note as well. And from individual care to public health surveillance. And the process moved to the four layers. I think this is the four important steps. The first is data collection, data organization, data interpretation, decision, and action. I think if you right now as a medical student, I think you already understand for this first step that important step for from the data collection, and the last part is where how we can do how we can make a decision and action to the community. And this is from individual record to early detection, I think is quite important as well. So quality medical record allow clinician or healthcare providers to, the first one is identify patient at risk of type 2 diabetes or pre-diabetes. And the second one is detect early warning trends, rising SpA1C, frequent infection or weight gain, and flag missed follow-up or regular medication pattern. And for instance, like the primary care dashboard that highlight patient with HbA1c more than 65%, which is uncontrolled blood sugar level, and not following up in 6 months, prompting outreach before complication develop. So as a medical record student, I have information you have to provide and good data for HbA1c and also the follow-up of the patient, so you can we can make a good decision before that the patient whether they have will come to complication or not in the future. So those things for identify patient risk of type 2 and pre-diabetes is matter. Also, how can we identify the early complication that will happen in the patient with diabetes from the primary clinical outcomes such as SpA1c level. I think those things I think is really matter for medical record and health informations. And this from the data to population insight. So when the clinic data are aggregated and identified, they reveal patterns that support preventive planning. The first one is geographic mapping and high-risk communities and monitoring community lifestyle indicators such as diet, physical activity, and evaluating the impact of health education campaign. And this analytic transform medical records into population intelligence, so helping policy makers target intervention and allocate research efficiently. And this is from to the support insight generation. The first one is electronic health record. I think you are familiar as already with this HHR about electronic health record is enable standardized entry, automated trend detection, and data sharing. And for diabetes dashboard, visualize risk groups and outcome in real time, and mobile community gaps, integrate patient report data such as diet log or daily step. Right now, a lot of applications that support can record the data, even from the software or web or something application. I think you have to familiar with this kind of things. And right now, of course, we have to talk about EI and predictive analytic, forecast high-risk individual using routine clinical data. And this is the good note that you have to take as well from data and action. And as I mentioned in early that the first one is data collection. In diabetes prevention is about the fasting glucose or BMI and standardized entries, detecting prediabetes cluster dashboard and report and community outreach educations. And also the outcome, this is the kind of those outcome from the example in diabetes prevention. I think in general, so you have to know this thing according to the diabetes prevention, such as recording fasting and PMI, as I mentioned before. And we have to empower a healthcare professional, right, such as nurse, educator, and medical record officer to transfer data into preventions. So quality prevention starts when every professional understand how to read, trust, and use health information. So as a medical record and health information, you have to provide the good data. So another healthcare professional can read, trust, and use those data yes to provide in the system. And in practice, nurses, diabetes educator, and medical record staff all handle pieces of the same puzzle. The first one is nurse collect and enter clinical data, diabetes educator interpret data for counseling and behavioral change, and overview of user answer accuracy, coding, and data flow. I think it's your expert. So you have to provide good coding and accuracy of data, and you can share to the another professor as nurse and a diabetes educator. So based on the data, we can do what thing we can do from this data, from this phenomena. So the accuracy of data and how you do the good coding, I think this is important things. And this also the core competencies in data literacy. If we talk about data literacy, of course, the first one is data awareness. So data awareness and also the quality is the basic important things if we talk about data literacy. And the next one is interpretation, communication, ethical stewardship as well. So according to those data, according to the diabetes prevention, if we talk about data literacy, the first one also you have to familiar as well with the primary clinical outcomes from patients with diabetes as I mentioned before. And for data quality, of course, the double checks, identifier, or how you code in the system, double check in the system, I think is important things. And for the communication as well, if you talk about communication, it's about translating data into the patient and team understanding. So explain your sugar control is improving instead of quoting numbers. So I think from those data, you have to, I can understand that the data is from the coding. So, but for your coding, if you share the data to the another healthcare professional, so yeah, you have to think what the meaning of your data. That's I think, but because nurses and diabetics got not familiar as well, I think not familiar at all from your coding. So that's why you have to. It's your job as well. And another common challenge is that also this is my pen as I read from the recent study that they provide the common challenges in the health informations. And the first one is documentation overload. So staff focus on from instead of insight, and low feedback loops data are entered but never returned as learning. Digital divided and even computer literacy across role. And the last one is system fragmentation from the clinic, laboratorium, and community data rarely connects in the system. And this is I summarized the strategies to strengthen data literacy. The first one is the joint training programs. Of course, from the program, we can empower nurse, educator, and medical record information students in the same sessions on electronic documentation and dashboard. And the next one is feedback dashboard. So we have to show how complete and timely entry improve population indicators. And interdisciplinary case review, we can use real patient data like to discuss prevention strategies and pay data safety stuff with beginners. And the last one is recognition and reflection. So celebrate teams that achieve data quality goals. So I think the most important is about your data quality. So that's why in the previous slide, when we talk about data literacy, the basic concept of personally, I think your data quality is matters. And this one, we talk about data stewardship. For data stewardship, we have to view data quality as shared ethical duty, not an administrative tax. And when every role value accurate information, trust increases and decision-making strengthen. So that's why how important the data quality you provide the system, because the other professional will take decision making. So before the high professional we do decision making, of course we have to really good data, right? So that's why providing good data and providing coding, providing data quality is matter before the hacker professionals or clinician or nurse take a decision in our place. And also, we have to tag like term literacy or similar with term intelligence. So enabling early identification of high-risk patient and focusing community educations. And this also could note that you have to, I remind to all of you that empower teams make empowering data. And also when nurses, educator, and medical record officers show data literacy, information become a prevention. This is also the good to note that information become preventions. And from this slide, we have to discuss about transforming health data into daily understanding and preventive action. So health data are the most powerful. So health data is the most powerful when they return to the people who generate them, such as the patients, families, and communities. And too often data stay in the report on hospital servers that this is also my personal experience as well. Well, the individual behind the number remain uninformed. So that's why you have to provide a really good health data, because that's thing is the most uh a powerful that is sent to the people who generate them, such as the patient, as a family and community. So those we really know their own the health data. And for engaging patient close the loops, because we have to do data, the first one is the data of course, and the awareness and also the behavior change. And the turning health record into everyday insights. So I think if we're talking about the turning health record in diabetes preventions, I think the most important is the body digital literacy coaching, and also we can use the reminders, app reminders. So when we talk about diabetes prevention, when according to digital literacy coaching, it is about teaching patients to understand their own data. So when your labs numbers mean session or short video tutorial, so this help the patient to understand their own data. And based on their own data, we have to provide some information using app reminder. For instance, is for turning follow-up data into reminders. Also, those things can improve the attendance or compliance of their medications, and such as text message when glucose check or clinic visit is due to as a reminder for them. Thus, I think this kind of things is quite important in diabetes prevention or diabetes management. So when we talk about the app reminder as well, this is my paper that's published in the of diabetes obesity and metabolisms, and we talk the evaluated about digitally as an intervention in improving glycemic hemoglobin level in patients with type 2 diabetes. And from this project, we have provided the 17 interventions. 17, yes, 17%, including single intervention and also multiple intervention as well. And this project also we focusing on digital assay interventions. After you can read by yourself as well. If you want to read in detail, just type the title in the Google and this project will pop up and you can read by yourself. And because my project is focusing on using network meta-analysis, so this is the main finding of my projects. We just focusing on components. So for the component of digital asset intervention in improving SPA1C level in patients with type 2 diabetes, which is the PSC, physical education on short message service and mobile application and telephone call. However, since this project focusing on digitally as intervention, so the first one, digital intervention, is short message service or reminder as well that I mentioned before. So this project is really support the importance of reminders data into the patients to improve their the primary clinical outcomes such as SPA1C level. Also, we can use mobile application and telephone call also significant as well in improving SPA1C level among patients with type 2 diabetes. So from these findings, social message services as reminder data or mobile application are the optimal digital assisted interventions in reducing SPA1C level. And healthcare professional, for example, like diabetes educator, can integrate digitally as an intervention complemented by educational program, particularly mobile complication combined with professional education program and prescribed education into daily care to control SPA1C level. I did summary with the suggestion from this project from the evidence from my paper. So we have to know that SPA1C level or cluster hemoglobin, the anchor metric in your digital workflow. So we have to ensure that every person with diabetes has up to date their SPA1C level result in the record. My personal experience when I work in hospital in such East Java. So sometimes the medical record is really late to provide the updated SPA1C level in the system. So I think this is worse because SPA1C level, actually the patient with diabetes have to control once in 3 months to provide the updated SPA1C level in the hospital or in the primary healthcare. So as medical record student and health information, you have to really update the SPA1C level so they can the most important, the clinician and the patient can know the trend or the pattern. Maybe like the patient with diabetes living 2 years with diabetes on within 2 years, they will know the pattern of HbA1c. This is matter because from this pattern of HbA1c level, the patient and the family or healthcare professional will know whether the medication or another program will successful or not in supporting HbA1c level in patients. And another one is the paid self-monitoring with timely human feedback. So combine application or device logging such as glucose meal step with source such as message from nurse or educator within set time window. For example, like within 7 days of new data to sustain behavior change and maintain HbA1c improvement. So the last one is protect data quality. So insight are trustworthy. And for medical record health information teams, so you have to standardize code and unit, check completeness and dates, and push clean data into the registry that automate critical lists and community summaries, turning routine entries into prevention actions. And for individual empowerment to population awareness, so for the if you talk about the population awareness, of course, from the individual level first. So person who see and understand their own data, so higher adherence to diet, activity, and medications. And the next one is community level. So if talking about community level, data visualization can drive collective responsibility. School, mosques, and local leaders can play prevention campaign as well. And the STEM level community feedback loops inform policy about the barriers such as cost access and literacy. And for the practical step for healthcare teams, so we can use simplified data language and some medical terms such as HbA1c level into relatable measures and glucose control score. I think this is not only focusing on medical record. For another like diabetes educator or nurses, also we have to change our term if you do health education in the community. And your visual tool, chart traffic light on icon to explain progress and promote co-ownerships, involve the patient in checking and update the records, and integrate education with data feedback. Each follow-up visit includes a data talk, and collaborate with local campaigns such as teacher, religious leaders, and peer educators who can share data-driven message in the community language. So if we're talking about good health information, so before conducting health education, so I had experience as well because last time, at the time, I did the health education in such a countryside in East Java. So sometimes we need the religious leader as well and peer educators to invite and help us to provide health information in the patient with diabetes. So that's why from this slide, I do provide about the importance of collaborate with local campaign is matter. And this call also the bridge between data and trust. So we have to trust grow when people see themselves reflected in their own health data, and transparent, respectful communication of information encourage shared responsibility for preventions. And this is the create a feedback cycle. So this is, I think, you have to think that you have to provide a better data, better understanding, better behavior, and better outcomes. So of course, with from the better data, in the last part is you can provide a better outcome from the patient, especially in patient with diabetes, also a patient in chronic illnesses. So this is the basic concept, the cycle of providing the good data. And when the patient understand their data, they own their health. So that's why I always remind not only to medical records, because since I'm also the diabetes educator, so I always discuss with another diabetes educator that when patient understand their data or when the patient really understand their condition, so they own their health as well, and they can do and they can improve and they can improve what can improve their daily habits in diabetes in their own diabetes management. And when communities see their trends, prevention becomes everyone mission. And this is from documentation to decision support, building smarter, fairer, and more connected prevention system. So the future of diabetes prevention depends on data ecosystem, not isolated records. So I think this is you have or known already from the patient, clinics, communities, and policymakers. So this is why how important how you code the data and provide data into communities, because policymaker will really understand based on taking decision based on the data. And this is also the record to the real-time decision support. So this is the future direction. Also, for example, like decision support is human review. We can use the in future direction, of course, is about the AI assisted professional guidance. So this also right now, I think everything is about AI, but I think we have to grateful because AIs can help us sometimes if you confused about the code or if it's about the providing data in the system. I think the AI can help me as well. So I think you have to take grateful because we live in AI era right now. And for example, like a AI assisted dashboard can alert nurse when the patient HbA1c trend suggests early deterioration, triggering proactive counseling before complication occur. Also, this is also the important of AI in supporting nurse jobs as well. So we have to talk about ethical and human dimensions. So privacy and consent must evolve alongside technology. Is about the patient should understand how their data serve collective health. And equity in access, we have to ensure rural and lower resource areas are
Dr.
not left
Debbie,
behind. Hello?
I'm sorry to interruption, but your
Hmm?
presentation time only left 5 minutes.
Okay, okay. Let me go fast. Okay, thank you so much for reminding. And
Okay.
the last one is human oversight. So machine can predict, so but only people can empathize, educate, and motivate behavioral change. So with the stuttering the system, I think the most important is promote community feedback. So we have to ensure that accurate insight data return to system for awareness. And we can integrate with digital health literacy programs, so teaching per professional and the public to understand and use the data wisely. I think this action we can to consider as healthcare professionals. First person is for healthcare professionals, so we have to record with purpose, and every data point is a life signal. And for educators, put data literacy into every curriculum, and for students, be the bridge between information and insights. And for leader and policymakers, make data system that empower, not overwhelm the front line. And yes, the conclusion from my presentation that the quality information is the foundation of every prevention effort. And also from the clinic to community, data must travel, organize, analyze, and return as knowledge. And digital literacy connect technology to humanity. For example, like tools alone doesn't don't prevent diabetes. Inform people use those tools too. And the last one is community engagement, close the loop. So when patient and family understand their data, prevention become collective. This I think important concept. So when patient and family understand their data, prevention become collective, and I think this can improve as well in diabetes preventions. And because you are right now is medical student information, I have provided some suggestion paper you can read by yourself as well, and you can get for free. The first one is predicting type 1 diabetes in children using electronic health record in primary care in the UK, development and validation of machine learning algorithm. So right now, some of researchers using machine learning as well to do research using electronic health record in, and this paper has published really good in the Lancet Digital Health as well. So, and from this paper, so I did summary, but using electronic health record with machine learning can warn early. So if clinics set the system to alert on about 10% of family care visit, it would identify through 72% of children who will develop type 1 diabetes within the next 90 days, giving on average about 9 days on advancing warning. So it's this kind of really interesting paper as well. And because right now we're talking about diabetes prevention, so I provided one good paper from the diabetes American Diabetes Association Professional Practice Committee. So this is about improving care and promoting health in population, standard care of diabetes 2025. So maybe if you're providing good health information as well, especially or particularly in diabetes, no, in diabetes prevention or diabetes management, you have to read this paper as well. So from this paper, you can provide you can get about the population health approach, and also how can we do the DCMES or diabetes self-management education support as a key moment in diabetes prevention or in diabetes management. And the last one, this is also is good as a review as well. It's about the common data quality elements for health information system. They did a systematic review, and when this I think this paper also interesting as well. So they review 67 eligible studies and found the 14 common data quality elements. The most frequent being is the first one is accuracy, completeness, and consistency, timeliness, accessibility, validity, and relevant, integrity, and security. So those things, I think the basic knowledge you have to really understand as medical record student and high informations. And thank you very much. That's all my presentation. I'm sorry for maybe over 5 minutes. I give the time to the moderator.
Okay. Thank you for Dr. Devi for such incredible and insightful presentation about diabetic prevention. We truly appreciate your contribution today. So now we will move to discussion segment. We welcome questions for participants. Please feel free to raise your hand or type your question in the chat box, and we will address them one by one. Okay. There's a question in the chat box from Mariam Shah. The question: many professions are involved in data recording like nurse, educator, medical record officer. How can we measure if their training really improves data quality and prevention outcomes?
Okay. Can I answer directly right now, right?
Yeah, you can answer it directly.
Okay, thank you so much. Who is the name? Mariam Shah. Okay, that's I think the question as well. So the question is, many professions are involved in data recording, such as how can we measure if the training really improve data quality and prevention outcome? I think the first one, because I had experience as well, inputting data in the Puskesmas or is in one of hospital in Malang, Indonesia. So the first one is you have to do the evaluation programs. So the first evaluation program every 3 months or every 6 months is really matters. So and as I mentioned before, another health professional such as nurse, dietitian, clinician, and diabetes educator, they did not familiar with the data or with the data recording. So actually, especially nurse, actually we know the basic one how we collect the data for the patients. However, the first thing that you have to do the training and also the forum group discussion as well with the medical record, so we can have a same mindset. Even we have different role, the role of our job, so we have to have a similar mindset how we do data recording. And we how if we're talking about measuring their quality, so the first one is training and the second one is to evaluation program. So within evaluation program we can improve and we can measure and improve another professional can also help in data recording. That's I think my opinion.
Thank you for your answer. There's another question in the chat box from Nazwa Kalista. Thank you, Mr. Debi Shahul Ramadan, for the insightful presentation on strengthening diabetic prevention through quality health information. You mentioned that fragmented and delayed data often weaken prevention efforts. My question: how can health information system in developing countries like Indonesia improve interoperability and data quality between clinics, laboratories, and community health programs, especially when digital literacy and infrastructure vary widely across regions?
Okay, that's I think the tough questions. Thank you so much from Naswa Kalista Mahari. Thank you. And this because if your question is really comprehensive when we're talking about the programs, right? So the first one that I do agree that the fragmented data right now, especially in developing countries, is really happen. Also, my personal experience, and also I read some paper they provided that's why health information in developing countries is bad. I think it's quite could not enough data. It's about the not the first factor is about the data is fragmented and delayed. And when we're talking about the how we can make sure the health information system in developing countries such as Indonesia or maybe like Southeast Asia regions. And of course, we have to talk about the government or health ministry. We have to raise the issue. The first one is the health ministry, and because I think the best solution is using digital literacy or digital education, and because the data is from the primary healthcare setting and move to the hospital, move to the clinics, and from the laboratory, and then we move to the community and we move to policy makers. And so that's why I mentioned in my presentation that the data from the primary healthcare will continue to the government, and government will take a notes the decision. I think the best way you have to raise this issue from the digital literacy to the policymakers, so the policymakers really understand about the issue, because it's quite difficult in developing countries. However, we have to try. As a medical surgeon, you have to improve your knowledge and how we can share our the problem about the data in our place, and the policymaker can really understand about this issue, and I think we can discuss about the solutions. I think that's all my suggestion. Any other questions?
Okay, thank you. And yeah, there is another question from Alins Amalia. My question is, in your evidence show that SMS and mobile apps help diabetes patients control their blood sugar. But elderly people are the fastest growing diabetes group and most cannot use smartphone or don't have internet access. Are we creating prevention programs that only work for young, educated people in the city while ignoring grandparents in village who actually need the most help?
Okay, that's good. Good question as well from Alinsi Amalia Rizky. Thank you so much for raise this question. Yes, right now we live in digital, and my project show that digital is as short message service, short reminder, and also mobile application, telephone call is the significant the most I think the most optimal in reducing SPA1C level in patient with type 2 diabetes. That's atau if we're talking about elderly, so that's why when so you have to make sure the first one you have to do the comprehensive collecting about their background. So sometimes the elderly stay with their relative or the family, and also they live single. So those thing is different thing if you talk about strategies preventions. So the first one if the elderly did not stay with their families, so when they control to the puskesmas, we have to give health education how important the reminder. So if they we have to talk their family as well, and we have to give reminder as well to their family. And another thing, if the elderly stay living or single living, so we have to discuss with healthcare professional owners or dietitian to do the home visit care as regularly as well. It's quite challenging. However, I had experience in East Java as well in conducting health education. If the patient, especially elderly, did not have as they're not supporting like internet, or they don't have the smartphone, we have to do home care visit as well regularly, maybe like once in 2 weeks as well. We have to make sure they're good enough, and we have to talk about the neighbors to support as well about the diabetes management as well. And if another digital, I think it's challenging in the end, we have to another profession we call it peer super education as well. So peer super education as well, in my paper, PSE also significant as well in improving SPA1C level. So if another solution or cannot support the digital as well, we have to take note. Another profession is called the PSC as well. It's called my suggestions. But I thank you so much, the agency. I think your question is really great.
Okay, our session is over. There's have one question, but sadly, our session is already done. Thank you, everyone with us engaging question and discussion. It's clear that Dr. Debbie topics generate a lot of interest. Now, we will present a certificate of appreciation to Dr. Debbie. Thank you, Dr. Debbie. Everyone, please join me
so
in
much.
giving a big virtual applause for Dr. Debbie. Alright, you may now return to the participant screen as we move to our next speaker. Thank you so much.
Thank you so much, everyone. Thank you so much.
Yeah, thank you. Alright, participant. Now it's my honor to introduce our final speaker for today's session, Professor Emily Chia Yusu, joining us from Taiwan.
Hi, good afternoon, everyone.
Hello, Professor.
Yeah, I'm good. So, should I share my slide or after the brief introduction?
Okay, I will do brief introduction first. Alright.
So now I can share my slides, right? Or later?
I will do brief introduction
okay.
first.
Sure, no problem.
Alright, so Professor Emily is a renowned expert in medical informatics, artificial intelligence, and precision medicine. She is currently a professor at the Institute of Biomedical Informatics, National Yangming Chao-Chung University, Taiwan. Holding a PhD in bioinformatics from Academia Sinica, Professor Emily has held key roles including serving as a visiting scientist at the United States National Institute of Health. Her research, which includes over 70 international publications, focus intensively on explainable AI, machine learning, and clinical decision support. Her work is pivotal in advancing AI-driven and clinically meaningful systems in real-world healthcare settings. Okay, Professor Emily, it's really a great honor to us to have you here. So, how are you doing today?
Can you hear my voice clearly?
Yeah, I can hear you.
Okay, good. Should I share my slides now?
Alright, but just before you start, there's a quick time management note. You will have 45 minutes for your presentation and followed 15 minutes for discussion. I will help manage the time. Alright.
Let me share my slides.
Alright.
Okay, are the slides available to everyone?
Well.
Okay. I have 45 minutes, and it's my great pleasure to be here at the 5th International Seminar of Medical Record and Health Information. My name is Professor Emily Su. I have been to Indonesia and I like it very much there. It's my honor today to share with you the topic about disease prevention. And I slightly changed my topic a little bit to from data to decision, explainable AI and computational health informatics for population health and care. Before I begin, this is the outline of my talk today. I will first talk about the introduction of myself, and after that, I'm going to mention how machine learning can help the health informatics. After that, I'm going to use 3 examples from the more basic research bioinformatics to medical informatics and so on. For the public health, I'm going to introduce how informatics can be used for disease prevention in epidemiology. So let me first introduce myself a little bit. Okay, let me use the laser. Okay, I got my bachelor's degree in computer science, and after that, I went to National Taiwan University and obtained my master's degree. At that time, I worked on artificial intelligence, which was not yet a popular research field. And after that, I obtained my PhD from Taiwan International Graduate Program. And I work on bioinformatics. So today I'm going to share with you my experience from the background as a computer science student to work on medical informatics. And after my graduation, I work as a postdoc fellow in a research institute at Taiwan. It is called Academia Sinica. After that, I work in Taipei Medical University, and then I just shifted to National Yangming Jiao Tong University last year. So if you are interested in studying Taiwan, please don't hesitate to let me know as well after the talk. So let's get back to our topic today. First, I'm going to talk about the theme of applying artificial intelligence and also machine learning for health informatics. So let's Look at this video. Nowadays, AI is very popular. As you know that there are many subfields in the field of AI. For example, we may use machine learning to be able to produce predictive models. Besides that, for unstructured data, for example, like a text or so-called natural language, we can also use computational techniques to analyze the text, especially nowadays. You may also know that large language models, LLM, such as ChatGPT, Gemini, they are very powerful and also very popular, not only for students, but also for faculty members. Besides that, if you have a cell phone, for example, I may talk to my iPhone or Apple Watch. So Siri is be able to respond to my questions. That is about speech recognition. Besides that, we also have the robotics or computer vision. Nowadays, processing is also a very hot topic in the field of biomedicine. So now, let me first talk about why AI or machine learning, they are so popular in recent years. First, due to the huge amount of data and also the dimension of the variables are pretty high. Besides that, the data itself might not be easy to be analyzed by traditional statistical methods. Therefore, we need a more advanced machine learning algorithms to help us identify the patterns from our data, and we can combine statistics, machine learning, and also the data analysis techniques. Together, we can come up with more information from our data. So later in my talk, I'm going to mention a process. Later, I'm going to talk about several examples. Most of them are about the collection of input raw data. After that, we must perform data preprocessing before we send our data into any data mining or machine learning algorithms. If we don't do this, we can also use the machine learning algorithms to analyze our data. However, without proper feature extraction, feature representation, or data preprocessing, it will be garbage in, garbage out. Therefore, having a suitable data preprocessing, it might be related to, for example, feature selection, dimension reduction, normalization, data sampling, so on and so forth. If we can apply a proper way to clean our data, we can have a more representative data set so that we can use machine learning algorithms to analyze our data and be able to get good results. So in the post-processing, the other focus of my talk today is the explainable AI, XAI. Recently, if you read articles from journal papers, you may discover that having a good performance or predictive performance is not good enough. Nowadays, people are looking for more explainable interpretations. So if you can interpret the results better, we can convert the input raw data to the information. And this will become a knowledge discovery process. So later, I'm going to mention several examples in three different aspects. They are all related to the knowledge discovery process. So in summary, the application of machine learning in the field of health informatics may include disease identification, personalized medicine, drug discovery, radiology, or medical image analysis, or even epidemic outbreak prediction. So next, I'm going to use 3 different examples from a more basic research aspect, that is bioinformatics. After that, I'm going to get into the applications of medical informatics. And finally, I'm going to extend the scope of my data to public health. So first, let's look at the examples from bioinformatics, how we can apply machine learning algorithms in the field of AI to analyze molecular level data. So if you have studied molecular biology or biology, you may notice that proteins are the molecules that have a function in the human body. So if you look at this figure, it is a gram-negative bacteria. There are 5 different localization or so-called compartment of the bacteria, including cytoplasm, inner membrane or cytoplasmic membrane, outer membrane, and the periplasm, the compartment in between, and also the extracellular space. So this example, I try to demonstrate that we can use machine learning algorithm to analyze the molecular part. I'm hearing someone. Okay. So next, I'm going to mention 2 different ways to solve the protein location prediction problem. Okay, so the first one, whoops, I heard some noise from the Zoom meeting. Oh, now it's much better. Okay, so the first one, we can use a very biological way to solve the protein location problem. So given a protein sequence, we have only the sequence without any wet lab experiment information. We want to predict or we want to guess where the protein locate in the cell in any of the 5 locations. So we can use a very biological way. In this case, we read from a science paper. It suggested that a protein is synthesized in the cytoplasm and it is translocated to different locations. For example, if we follow the path, it will be translocated to the inner membrane. If we follow another path, for example, this one, it will be folded and directly transported to the extracellular space. So based on this observation, we discovered that proteins are translocated to different locations based on different biological property. So these properties may include, we discovered that for the proteins translocated from cytoplasm to, for example, inner membrane, they usually come up with a biological property with, for example, signal peptide or having an alpha helical structure in the secondary structure. So we make use of these very customized biological properties to incorporate these kind of features into our machine learning algorithm. So these are the very compartment-specific biological features that we used for the prediction of protein location in a cell. So if you look at the system architecture, given a protein sequence which is composed by 20 amino acids, we try to extract different kind of biological features from the sequence, and after that we use a customized set of features and put the features into machine learning algorithms, try to identify the patterns within different locations so that we can predict the final location of a protein without doing any wet lab experiments. So besides the first way, which was a very biological way, my background is computer science. So given the same research problem, how to accurately predict the location of a protein based on only its sequence composed of 20 amino acids. So how about we treat the protein as a text or as a paragraph, as a document, and we try to predict the class of the protein. For example, if you read a newspaper, then you will know the category of a newspaper. For example, if you see like a president of America, the United States, if you see Donald Trump, then you will know that it's a document about politics. However, if you like my children, they like movie stars or they like pop singers. For example, my children, they like pop singers from Korea, like Blackpink or K-pop, something like that. Then you will know that, oh, this is related to the singers or movie stars. So let's go back to the protein sequence. We try to regard the protein sequence as a document, and then we try to use a way to define the keywords such as Trump or K-pop or Blackpink in the field of protein sequence. So we use a way to identify the keywords or so-called patterns, and then we give them different ways. After that, we use machine learning algorithms to predict the location of the protein. So by doing that, okay, we can not only get a very high predictive performance, but be able to interpret the results and be able to know which are the patterns that can represent different location of a protein. So we further extend our research to identify potential allergens from proteins, and also we apply our method to investigate the antibody antigen interaction, especially when we want to perform vaccine discovery or if we want to help the drug discovery. Okay, so there was about how to use machine learning algorithm to analyze a very basic molecular level research question. Here, I mentioned about the analysis of protein sequence. Without doing any wet lab experiment, we can analyze only the sequence patterns and be able to propose related candidates for the protein function. Okay, so next I'm going to get into the second topic I'm going to share with you today. It is about the application of machine learning in the field of medical informatics. So here in the second topic, I'm going to focus on the individual patient level. So previously, if you are not familiar with molecular biology or genes, proteins, you might find it a little bit difficult to understand. But next, I promise that it will be much easier for you guys because it's more related to clinical practice. So now in the medical informatics, the first example I'm going to share with you is about a disease, diabetics. I think maybe your friends or your family may have DM. Here we collaborated with a clinical physician and we collect diabetics patients' data from the hospital. The goal of our research is to predict who are the diabetics patients that might have eye retinopathy problem, meaning that, for example, they might not see clearly all of a sudden, or their eyes have problems. So we try to identify the diabetics patients with higher risk in their retinopathy. So we perform data collection and we pre-process the data. After that, we use different kind of machine learning algorithms, decision tree, neural network, logistic regression, support vector machine, try to identify before the patient really get worse in the retinopathy. We can predict in advance to remind the patients and also the doctors about those higher risk patients. So here, this is our publication. Although this journal is not very high in the impact factor, however, this is one of the most cited article published from my lab. The reason is that in our study, we not only achieve a high predictive performance to predict who might be the diabetic patients that will have retinopathy problem in the future, but also we can propose explainable interpretations. So this is our results generated by decision tree. If you or your family they have DM diabetics, you may take a look at this pattern. From our data, we suggested that if a DM patient has already used insulin injection to control the diabetics, then you go to here, they tend to have higher risk in the eye retinopathy problem. However, if you have not used insulin to treat your DM, further we look at the duration of years. How many years have you had diabetics? If it is already more than 7.5 years, then you need to be careful. Your risk for having the eye retinopathy problem is also higher. However, if you have not used insulin and your duration of year is less than 7.5, then your risk could be slightly lower. So the physician will suggest that for patients with higher risk, you may need to have your eyes checked by the eye doctor every 3 months or 6 months. However, if you are in a lower risk group, then you may only need to consult with the eye doctor maybe every year. Okay. So this is our first example about how to identify or predict who could be the DM patients that might have eye retinopathy problem. So next, I'm going to share with you the second example in this medical informatics. So the second example I'm going to share with you is about the IVF, in vitro fertilization. So in Taiwan, many couple they try to have children, but no matter how hard they try, they just cannot get pregnancy after their attempts. So many couples will go to Taipei Medical University for IVF treatment. So we have a huge amount of data in our database. Therefore, we collected about 70,000 treatment data from our database. And our goal is to identify who could be the mother that can easily get a pregnancy after the IVF treatment. So these are the variables that we collected during the IVF treatment, and the goal is to predict who are the mothers who can get a successful pregnancy after IVF. So the variables may include, for example, cause of infidelity and a source of sperm and eggs, whether the eggs is freshly taken or frozen. And also the ovarian stimulation protocol, duration of infertility, and many other variables related to IVF treatment. So after we collected the data, we used machine learning algorithms, including logistic regression and also random forest, to construct a predictive model to identify who are the mothers who tend to have successful pregnancy. So as you see that our ROC curve shows that we have a pretty good AUC. Besides that, we try to interpret the patterns a little bit more. So our machine learning algorithm can rank all the variables from the most important one all the way down here. So you can see that our study suggested that variables such as ovarian stimulation protocol, total frozen embryo number, female age, embryo transferred numbers, or duration of infertility, cause of infertility. These are all important variables that can influence the results of your IVF treatment. So we further propose to use this kind of pattern interpretation or visualization techniques to look at the propensity of each variable for the pregnancy success rate. So this is a very interesting example over here in the sub-figure B. So this figure demonstrated that the x-axis are the female age and the y-axis denotes the propensity or the probability to have a successful pregnancy. If this line is above 0, it means that it is easier to get a successful pregnancy after IVF treatment. However, if it is below 0, it suggested that it is unlikely to have a successful pregnancy. So you can see that the female age cross over here at the age of 38 or 39. So this suggested that if the female age is more than age 35, 38 or 39, it is difficult to have successful pregnancy. The next figure demonstrated that our method can also interpret the categorical variables. So if you look at this figure, you can see that it is about whether the egg was taken freshly during last cycle when you went to IVF treatment, or the egg has been frozen before and now defroze for the IVF treatment. So before I do the analysis, I will suggest that, it's like a food or vegetable. Fresh is always better. However, in the contrary, our analysis suggested that, you can see that frozen eggs, they have better pregnancy success rate compared to freshly taken eggs. So now we further
I'm
look at
sorry.
the reason why. You can see that we look at the biomedical literature and discover that the frozen eggs, they are usually taken when the
I'm
mother was
sorry,
younger.
Professor Emily.
Maybe she didn't want to have kids, or she didn't get married, but she want to have her eggs frozen in case she want to have kids in the
Professor.
future. So that's why we can
Alright.
see that the frozen eggs have better pregnancy outcome from our analysis. If we look at
Professor.
another variable, the female age, we can see that uh, the rate of having, for example, abnormal situation from the egg, like a abnormal chromosome, something like that, the rate is only 10% for women aged less than 35. However, it will be increased to 30% at the age of 40 and even increased to almost 100% when the age is greater than 45. So this suggested that our variables selected by machine learning algorithm, they correspond very well with biomedical knowledge. Okay, so we try to not only publish papers, but we hope that our research finding can be used to help clinical practice. So that's why we apply for patents in Taiwan, and we also construct a web and also an app on the cell phone so that we can help the mothers who try to have baby through IVF treatment to predict the clinical pregnancy outcome. Okay. So the next example, the final one, that I'm going to share in the field of medical informatics. It is about the biomedical text mining. So as you can see from my presentation, up to now, I talk about the structured data. I have this data, and we might have already a table, no matter it is a text file or CSV or any database file. However, nowadays, the trend of machine learning has been moved to the unstructured data. What does it mean by unstructured data? It means that the natural language, written or spoken. So the last example in the field of medical informatics, I'm going to share with you the theme of today, how to use text mining techniques to analyze medical record. So here we collaborated with doctors from the hospital, and we try to look at how to identify the associations of clinical and social parameters with violent behavior. for the group of psychiatric patients. So this figure shows an example of the written psychiatric patient evaluation form. As you can see, it is unstructured data. We don't have a table with different variables and different samples to analyze, but instead, we need to use natural language processing techniques to first extract these keywords and be able to look at their relationships. So the difficulty in the analysis of unstructured data is that in the written evaluation form, we may have like
Professor
typos
Emily,
or even, hi.
I'm sorry
Uh,
for interrupting.
my
I
time is up.
kindly remind you that our presentation session only 5 minutes left.
Oh, okay. So I will speed up. Okay. Okay. So for the unstructured data, and we can come up with the identification of the association rules. For example, if you have financial stress, or if your gender is male, or if you have a drug use, you may have a higher tendency for violent behavior. So finally, I'm going to use the last 5 minutes to show you the last part about public health. In Taiwan, uh, my hometown is from southern part of Taiwan. We have dengue fever every year. So we try to look at the correlation of air pollution with dengue fever outbreak. So besides the traditional variables, we also collected AQI. And then we can see that PM10 and PM2.5 tend to be higher when there's no dengue fever outbreak. So we include the air quality index and it helps the prediction of the dengue fever outbreak. Okay, so we further interpret the important features with our propensity plot, as I shown before. So lastly, I'm going to share with you a study with my student who has already graduated and become a faculty member in the Monash University in Indonesia, Athena. So she collected the data about COVID-19 and we published several papers related to info epidemiology. So the first one I'm going to share with you is we try to collect the Google search trends from Google and try to predict the confirmed case and also death case in Taiwan related to COVID-19. So you can see that this is the time and we collected the Google relative search terms and we also use a heat map to visualize different correlations in different cities in Taiwan. So at that time, we didn't have many COVID-19 cases. Therefore, we also collaborated with Professor Shin from South Korea. And our analysis suggested that the idea of using Google Internet search term or this kind of relative search volume to analyze the confirmed case and death case are usually more popular or stronger in women and also younger age group, especially in the higher infected areas. So besides that, we also try to use data from the United States, and we try to use some GIS method to investigate the transmission of COVID-19 in United States. So finally, I would like to use this figure to demonstrate that the theme of my talk today, I try to introduce. We can use machine learning techniques with a proper interpretation. So here, the red spot indicates the hotspot for COVID-19. This is February, March, April, May, so on and so forth. As you can see, the COVID-19 was transmitted into United States from the West Coast all the way to the East Coast, and then it go down to the South part, and finally it moves up to the North and the Central part of the United States. So, as a take-home message, I would like to emphasize that nowadays, with the help of many LLM tools, you may easily try to write a code to use machine learning technique to analyze your own data. However, the importance is about the post-processing, how we can interpret our findings more, how we can contribute to the research community. So if you can use explainable AI, XAI, I think it will benefit in your research field so that we can bridge the gap between basic research and also clinical practice. So finally, I would like to thank the opportunity for the organization committee to invite me to give this talk online. If you want to study in Taiwan, please feel free to join us. Our institute is Institute of Biomedical Informatics, NYCU. And also, I'm also a core faculty member at the TIGP in Academia Sinica. So we provide pretty good stipend. Some of them are about 1,000 US dollars per month, okay, for like 3 or 4 years. So please don't hesitate to let me know if you are interested in studying master or PhD degree in Taiwan. So finally, I would like to thank the lab members for their work, and also I thank my universities for their support for my research topics. Okay, so thank you very much for your attention, and I would be happy to answer some questions from the students. Thank you.
Okay. Thank you to Professor Emily, who has shared incredible and powerful presentation. Your insight on explainable AI is really great, and we truly appreciate your valuable contribution today. So now, everyone, we will move to our final discussion segment. Participant, please feel free to raise your hand or type your question in the chat box, and we will address them one by one.
Okay, I have seen one from Tanya. So it is about as AI becomes more integrated into clinical decision making, how do you see the role of explainable AI in ensuring ethical transparency and trust among healthcare professions and the patients? Yeah, I think that's a very good question and also a very basic and an important one. No matter how the advance of AI or deep learning or any computer techniques, we still need to focus on getting the IRB or having the info consent first, especially when the interpretable AI. We need to make sure that if you are using, for example, the examples that I have shown, We need to make sure that we got the info consent from all the patients. Besides that, we need to make sure that those data or information has been de-identified before we conduct any analysis to make sure the privacy of patients. And for the explainable AI, that's a current trend in the field of AI. However, the explainable part will not be able to trace back to the privacy information of each patient. For example, I will not be able to know which patient got these rules, but we try to propose a knowledge finding result without invasion to the privacy of each patient. Okay, so not sure if I answer your questions. Okay, due to the time, I think I will have, oh, the next one. Okay. The next one is as AI systems rely heavily on data, how can we prevent algorithms bias that might arise from unequal or incomplete health data so that AI-driven decisions remain fair and beneficial for all populational groups, especially in low resource setting? Yeah, actually, that's also a very important question. In fact, when we use AI or machine learning algorithms to deal with medical data, one of the most common problem that we may facing is that the data set itself could be highly imbalanced. For example, if I am analyzing a rare disease, in the patient population, we can see that this is the amount of patient with that kind of rare disease. However, over 90% of our data, the patients will not have the rare disease. So if we directly use the whole data set as a very imbalanced situation, put them directly into a machine learning model, our model will try to optimize the prediction accuracy and predict all the patients as not having the rare disease. But this is not what we want. It will sacrifice the sensitivity of our model. So we need to use different kind of techniques to first balance our data a little bit before we send them into machine learning model so that we can avoid possible selection bias or this kind of imbalance problem. The other situation we also deal with is the missing data. For example, if we are analyzing medical record, it is almost impossible that we can have a very perfect data set with 0% missing value. So we need to decide if the missing rate is too high. For example, over like a 50% of the variable is missing, then we may discard or we may delete the variable. However, if the missing rate is like 30% or 20%, we may use the existing values and use different kind of imputation techniques to fill in the values into our method. So hopefully it can prevent the situation that of having a bias in our predictive model. Okay. For the low resource setting, we need to know which are the important variables or which are the most accessible variables that we have so that we can decide which variables we should include into our study. Okay, the final one, let's see. Okay, AI prediction results often work well in one country, not in others. So the question is, what steps are needed to make these models stay accurate across different regions and different health systems? Yeah. I would say that that's a difficult question for any research group in the field of medical informatics. However, the current solution is nowadays people try to collect multi-nation data. For example, for the different studies, we not only use data from Taiwan, but also try to use data from Indonesia, from Japan, from many countries. That's the ideal situation. However, if you cannot collect data from multi-nations, maybe you can start from a multi-center data set. For example, in Taiwan, I may collect data from National Taiwan University Hospital and also collect from Taipei Medical University Hospital so that we can have a multi-centered data set to analyze. If we have the multi-center data set, we may use one hospital as the external validation, which will not be used to train your model or to select your variables or to tune your parameter. The external validation data from another hospital will only be used as an independent test to show the true performance of your machine learning model. So this will ensure the robustness or the applicability of your method. If your machine learning method can also work well on another external validation data set, then you can claim that your research question has been solved not only in the data set you use to train your model, but it can also be applied to different regions and also different hospitals, different health systems. So yes, it is very important. Nowadays, people try to use external validation set, especially from multi-centered data set to validate our approach. Although it is not mentioned in the question, however, I would suggest that the other trend is to use multi-module, multi-modality, meaning that we may collect medical record. We may also have the lab test data, your blood examination results, or you can have the medical image result. For example, like X-ray, CT, MRI, or ultrasound image. If we can combine more types of data to form a multi-module research, then your approach has been validated by different sources of data. In this case, we can claim that our algorithm also work on different regions and also different hospitals. Yeah. So I think those are good questions. So if you have any question, if time is not allowed, please feel free to send me an email. Or if you want to have a short discussion, you can also let the committee members know and they will pass your questions to me. Okay.
All right. Thank you for participant question and also to Professor Emily for the incredible answer. Once again, our sincere appreciation goes to Professor Emily Cha Yusu for sharing such valuable insight with us today. We will now
Thank you very
present a
much.
certificate of appreciation for Professor Emily. Everyone, please join me giving a big virtual applause.
Thank you very much. Thank you.
Thank you so much, Professor. Okay. Now you may return to the participant screen as we move to our next agenda.
Sure.
All right, thank you. Ladies and gentlemen, that's conclude our speaker session today. On behalf of the organizing committee, we extend our deepest gratitude to all our distinguished presenters and to all participants for your active engagement. It has been an honor for me to serve you as a moderator. Now, I will return this session back to our Master of Ceremony to continue the program. Thank you.
Okay, thank you so much to our moderator, Sofian Jani Auranisa, for your valuable contribution and dedication to these sessions. We would like to extend our sincere appreciation to all distinguished speakers for sharing their knowledge and insight during the presentation session. Ladies and gentlemen, the next agenda, to all participants, please be able to do the post-test. You can access the post-test that has been shared by the committee in the Zoom chat. We also kindly remind our participants to fill out the second attendance form as part of today's international seminar attendance requirement. The attendance link has been shared in the Zoom chat box and will be only active for 30 minutes. Please make sure to complete it on time. all participants who have completed the post-test. Ladies and gentlemen, next we would like to give appreciation to participants who have actively asked questions during the seminar session. So, we would like to congratulate Alins Amalia Rizki. Congratulations to participants for your enthusiasm and participations. The name of best participants, please contact personally to the committee for further information and confirmation. Ladies and gentlemen, we have now reached the end of today's international seminar Medical Record and Health Information with the term From Data to Decisions, Leveraging Big Data for Population Health and Preventive Care. Before we officially close the event, we would like to kindly invite all participants to turn on your cameras for the documentation sessions. Please get ready and give your best smile for our group photo. I will count from slide 1. 3, 2, 1. Slide 2. 3, 2, 1. Oh, sorry, slide 3. 3, 2, 1. Slide 4. 3, 2, 1. Slide 5. 3, 2, 1. Slide 6. 3, 2, 1. Slide 7. 3, 2, 1. Slide 8. 3, 2, 1. Okay. Thank you for your participation to all participants. We hope this international seminar brings valuable insights and inspiration to all of us. See you in our next event. Wassalamualaikum warahmatullahi wabarakatuh.